Doctor. Yes, we can proceed.
Okay. Wish you all a very good evening. We are fortunate enough today evening to have amongst us Dr. Karunakar Marikinti. He is a world famous person so far as hysteroscopy and infertility medicine is concerned. Regarding his introduction, actually, if I keep on introducing him, it will take 1.5 to 2 hours at least. But I will try to tell about him the salient features about his achievements. He is MD, CCST, FRCOG, MSc, reproductive endocrinologist, obstetrician and gynecologist with Wellness of Women Clinic, London, Cambridge, United Kingdom. Regarding his expertise, he has got lot of expertise. Some of the important ones are simple, complex female and male infertility, multiple miscarriage, complete range of IVF treatments including genetic testing, failed IVFs and complex infertility and sexual dysfunction, one-stop fertility assessment, ACO SY, most economical and patient-friendly patency test, fertility preservation and oncofertility. He is an expert at office hysteroscopy, 3D, 4D ultrasound in obstetrics and gynecology. It is not only this, he has got several other important things, like he has got a lot of experience since reproductive endocrinology since 2001 till date, that is more than 20 years. He was in United Arab Emirates from 2013 to 2021. Primary, secondary, and tertiary care of male and female infertility in world's leading centers run by world's experts, utilizing most advanced equipment, inclusive of genetic screening of embryos, reproductive immunology, protocols under strict European ethics and patient accountability. He has worked at Bourne Hall Clinic, the world's first IVF center we all know. He has also worked at London Women's Clinic, Hearts and Essex Fertility Center, Care Fertility. He is an independent ART specialist, then ART consultant role. He has worked upon egg collections, embryo transfers, research experience in reproductive medicine UK. From 2002 to 2007, he worked at world's first and one of UK's most trusted fertility centers. Clinical trials as principal investigator in several research papers. One of them is Tertiary IVF Center in Cambridge. He has worked at Tertiary IVF Center in Cambridge. He has been co-investigator in several research papers that have come out in last few decades. He has several contributions in reproductive medicine books, like he has authored a chapter on original data on diagnostic hysteroscopy in assisted conception, textbook of in vitro fertilization and assisted reproduction, the famous textbook written by P.R. Brinson. He had several presentations in reproductive medicine all over the world, I can say. He was there at Belfast, at Georgia, USA, and Barcelona, Spain. Twice he has gone to Barcelona, Spain to present his paper. Several times he has gone there thrice. Then he has presented a paper on Washington in 2007 and Spain, at Madrid in Spain, Texas again USA, and he has also contributed in human reproduction. The topic was miscarriages, effect of age, ethnicity, and history of infertility. So if I keep on reading, it will take another half an hour at least. So I don't think I should come between him and the delegates who are so eager to listen to him. I just have to add that to spread knowledge, actually it is difficult. It is just like a candle. First it has to burn and then only it can give light. So Dr. Manikinti, with his lot of burning in the past, he has gathered the experiences and now he's going to share his own experiences and learning to all of us so that we can learn something from him and change our clinical practice towards a better care for the women of our country. Thank you, Dr. Karunakar, for being amongst us today. And I also wish to thank Dr. Sashibala and her team from Aveta IVF, especially Patna, and the UNS people who have organized this program. Thank you very much. And I once again request Dr. Karunakar to, the stage is yours, sir, and you please start your deliberation. Thank you.
Pranam, everyone. Are we waiting for more delegates or am I starting now?
No, we are starting. This is a faculty link, doctor, actually.
Most of the delegates have joined online. So
Yeah.
it is basically being transmitted
I
online.
see around 10 participants. Is that what
Yes.
you registered?
No. Actually, doctor, this is a
Yeah.
faculty link. Here only faculty members are there, and other remaining doctors, they have joined in delegate link. That's a live link
Okay.
stream on yeah, YouTube and other.
Your audio is interrupted. I'm not able to get your audio. What about my audio? I just want to make sure
Your
my
audio
is...
Yeah,
is absolutely fine.
Okay, so there are some delegates or some audience listening. Approximately, do I know the number? And also, someone can help me. They're all gynecologists or IVF practitioners or hysteroscopy practitioners or any residents, professors. Professor Anita, if you can just give me a glimpse on who are these delegates so that I can titrate my language more appropriately.
I think
And also,
it is a mixed population. Some of the professors are there, some gynecologists, and I think majority of them are infertility specialists, and few of them are actually doing hysteroscopy, and most of them are learning hysteroscopy.
okay, so in which case the title that I chose was to introduce hysteroscopy and ultrasound as diagnostic and screening modalities, predominantly in the assisted reproduction, but there is an overlapping gynecological practice. We cannot totally separate them. So I would pitch in some slides may be unnecessary for some of the senior people, but for some it is it is very essential. So it's hard for me without actually looking at the audience and interacting to begin with to titrate the intensity of the presentation.
So basically this program has been organized for infertility specialists doing hysteroscopy and fertility enhancing surgeries.
Yeah, so I have prepared those two presentations predominantly, but no, assuming that there is some overlap of general gynecologists, so there is a general introduction to ultrasound and then moving on to the ultrasound in ART. Again, hysteroscopy is predominantly in ART. So that will be the remit. I'm always open to add on or bypass some of the slides as needed. I was given a couple of hours, but now the time is consumed, almost 45 minutes is gone. So somebody has to guide me, my time from now for each lecture. Can anyone help me with that?
We are not having any lack of time. It's up to you. I came to know that you are busy today and you have to leave for some.
No, I'm not busy, Professor. I don't use the word I am busy. I stopped that language some time ago. I don't wear clock. When I start, and it's only when the listeners say to stop, until then I continue purely to make a clarity. Is the whole purpose is to give a clarity on an issue that we take, and accordingly, I'm willing to be flexible. I don't have taken any commitments for this evening. I completed them for this
Thank you
evening.
so much for that. I think we'll love to listen to you as you keep on teaching to us, and you feel like that now you have done the justice with us, whatever it
So
is.
I'm
So we
just
we are
curious.
eager to listen to you as much as you can
Okay.
for the evening today.
Nakul, any idea the delegates number or audience number actually? Just opening the
Yes, shortly
presentation.
we are sharing, doctor. Shortly we are sharing.
Okay.
Yeah.
So someone has to assist me here to say the screen that I'm depicting is clear. Yes?
Yes, the screen is clear.
Okay. And my audio and video is clear, then I'll move on.
Yes,
As I said,
yes.
there are three sections to it. Predominantly, having now known that ART will be the 80-90% of the compelling theme, and the 20% is that what is behind it. It's almost like a foundation. So I will take on, to summarize what I learned, the hysteroscopy and ultrasound from 1985 at Allen Institute of Medical Sciences. Now we are almost coming to 2025. So it's around 40 years of practicing these two diagnostic modalities in women's health. So therefore, my intention was to be the interface between women's requirements, both at primary, secondary, and tertiary care needs of a general gynecology or assisted conception, and the clinicians who may be again providing primary, secondary, tertiary care to infertile couple and an overlapping gynecological pathologist. They are symbiotic, they're together. We can't separate. Wherever I'm setting up a hysteroscopy service, there is always an ultrasound machine. And there are times where ultrasound machine, I'm actually buying the hysteroscopes in second hand and pediatric cystoscopes. I'm organizing in a way that I'm delivering hysteroscopes also. For example, destination is Pakistan. I've been traveling recently because they're giving me access, and I'm being accepted as somebody to introduce hysteroscopy and ultrasound to them in a very, very aggressive way. So I'm even buying used pediatric cystoscopes to train gynecologists in Pakistan, where they never seen a hysteroscope in many parts. And ultrasound again, I'm struggling. And just to let you know, I just broke a 3D ultrasound card and used one to demonstrate to you how the probe head will work when you're going to do ultrasound. So I'm more like a hands-on person. I really like PowerPoint presentations and theory. And I have this to share with you how I'm going to assess the female pelvis entirety, both ultrasound scan, contrast scan, and then combined with hysteroscope. And the reason being, it's our third eye. I'll be time and again using some Sanskrit words in between because I'm in love with Upanishads from 1989. So whatever it is that with the same sound that I hear, it's going through me to you. That's nothing that I'm creating. I'm just a conduit for the knowledge that's in the space, in the air. In that note, I will take on the word effective use of ultrasound, not just making an ultrasound report by a radiologist, 2-page report, but they don't write antral follicle count. They don't write the quality of endometrium and the cyclicity. So I've seen over and over again, originally from Tirupati, 1917-85, I did medicine, and then 6 years in AIMS, and since 92 in UK. Luckily, I've been in the institutions. Luckily, I had the opportunity to be driven and trained in a systematic way. There are few privileged women and hospitals and doctors who are in a very systematic locations where the maximum expertise available to the minimum number of women on planet Earth. So therefore, it prompted me to start a company called Wellbeing of the Women London, which is a free telehealth company during the COVID, and where I do free consultations, talk to doctors anywhere on the same day on any of the cases that they're handling. That's where the equitable or equity comes from. equality and equitability or equity is different in the sense, independent of the resource limitations, they will receive free consultation from me, free protocol from me. Same applies to the clinicians. If they want to look after their women, adolescent to menopause, I'm willing to assist by giving written instructions, guidance, hand holding, career guidance, and so on and so forth. Nobody needs to pay me. If they're willing to pay, they can pay. If they can't pay, there is no need to pay. It applies to the doctors, nurses, patients, and their family members. So that is just the overview. Again, my job is not to tell what I've done in my career. I didn't send CV deliberately until yesterday evening when doctor asked me, Shashibala, to send the CV, but I didn't send. I just sent my business card. We could have saved some time today, Professor Anita, reading my CV. I could have saved another 10 minutes to teach you. So there are laws of learning and there are laws of teaching. And since I'm a yoga practitioner, I will be teaching what is not applies to me, but whatever applies to you. But I don't know exactly, but we have a clue now. You are likely to practice hysteroscopy and ultrasound in caring your women better. For at least for 1.5 to 2 hours, please keep your brain dedicated to me. Remove some of the concepts that you may have. So be the 6 o'clock cup. Every other cup is less efficient in retaining the knowledge. So it's almost like you all know Vivekam, Vairagyam, Shadguna, Sampatti, and Mumuksha. So these are the characters of Siksha, or somebody who want to receive knowledge or some sort of guidance in whatever we are going to do. So if you are in this zone and I want to play in this role, it's just a role play temporarily in this 2 hours or 1.5 hour. This quote is by Krishnamacharya, who is the first yoga teacher in Mysore Maharaja Palace, South India. And you may know him, his relative B.K. Iyengar. He went with one of his dhoti to London to teach first time yoga to English people long time ago, 1984. So I'm saying to you, my guidance to you would be, whatever I believe, I feel that you might add to your armory from tomorrow, how you care even your women better with ultrasound and hysteroscopy. So I want to give you practical knowledge, but without MBBS, we cannot do house surgency. So I need to emphasize on a lot of theoretical foundation that you need to feel. The more convinced you are, the more conviction you have to handle this hysteroscope in your hand will determine your, again, I just hold this to everybody. It's almost like telling people you're doing otoscope. It's that simple. So ultrasound is simple, hysteroscope is simple, and it is safe, and it should be the gateway to women's diagnosis and infertility or otherwise. 80 to 90% of the success in treatment comes from diagnosis, and not just diagnosis, accurate diagnosis and differential diagnosis. So I will be echoing these pictures. This is where the IVF was invented. This is Bone Hall Clinic, behind which there is Bone Village. That's where I live since 2000. Again, so let's say that I deal with 100 gynecologists as a group from now. We need to form in a way that some of you become the leaders. At least for every 100, I want one leader, which means if you have 100 ultrasound machines in your area, one of them should be the most advanced machine. If you have, let's say, 10 hysteroscopes, one of them should be the shaver system, which is the most potent and least side effect driven and least learning curve driven operative hysteroscope, being the shaver system. So that's how it should be. Somebody has to take leadership role to provide the tertiary care, both in endoscopy I will be restricting myself to histoscope, and somebody has to take a lead role for the 3D and 4D usage ultrasound. I will be showing their merits, distinctive role of tertiary care provider, tertiary skills over a long. Now, it's not about how many qualifications that I have or we all get or how many hospitals we open. If majority of the women in our community receive gold standard care, that's when we are worth it. Now again, there is ISWOG. I will encourage all of you, International Society for Ultrasound in Obs and Gynae. Every time, every 6 months, I go through the entire work that they do. It just melts my heart. It's almost like Buddha trying to teach something in entire areas that we traveled. Or if you take Shankaracharya, he took, as though somebody asked him, he gave a job to him to give wisdom to everybody wherever he was walking across India a few times from north to south. So ISWOG resembles to these two to me. Of course, Buddha remains quiet, but ISWOG is not quiet. They're like cancer. They have an outreach ultrasound training program. The minute you tell me you want to be trained in ultrasound, they're the first people to send me as their representative to train you, whether it is a primary skill, secondary skill, or tertiary skill. So in other words, the training's vision is that every ultrasound scan provider globally, not just few privileged places, is competent that the diagnosis of the condition is effective. It's not about scanning and making a report. You are diagnosing a condition. You're not just doing a technical report. Now, that condition is effective, that it affects the women's health outcome, and it has to improve in a positive way. So there is a lot of links in this statement. It's not a simple statement, I'm a good ultrasonographer, I can diagnose fibroid, adenomyosis, cancer. Um,
I
can
request please
we?
mute yourself.
Yeah. No, you should be able to supersede sometimes. This happens. So again, the motto is that it's not about you, it's not about that a good ultrasound is useful, but it's about globally there should be competency, and so that women's health outcomes should improve. It's not about that I scan. I want to train 100 of you in an entire state of Bihar, and that 100 will train another 1,000 in no time. Same applies to histoscopy, same applies. I love hands-on training. So if I'm passing some of the slides very fast, forgive me for that, because it is just to expose you how efficient we can improve the conditions by doing a competent ultrasound and histoscopy service. So the key points you all know, but just the names and nomenclature, I want you to be aware that adnexal masses, there is a classification that we need to follow. Endometrium, we have a different name now. How do you classify endometrium? Whatever age, adolescent to menopause, you need to use international standard glossary nomenclature. And for myometrium also, it is ideal, optimal. We all have a uniform data reporting system. And then same applies to the pain, the leading cause being adenomyosis or endometriosis. So now whenever you pick up a report system, I tend to do 28 to 30 things when I scan a female and report it and give it to her, draw the pictures on the back side of the page, and then the recommendations also included. These templates will be freely shared to you once you say hello to me on a WhatsApp. Then I'll be able to send. These are the templates that I use for histoscope reporting and the ultrasound reporting, so that once the logistics, it's like an application form. You can't just get through the next page if you don't fill the first page. It won't let you go. So around 28 to 30 things you can see in 5 minutes of doing a detailed ultrasound. And same thing applies to histoscope. Almost 30 different things you can see in about 5 minutes. So once you are aware of those 30 points irrelevant to their clinical condition management, it will be better for the patient. If I mention that, as I said, I need a structured learning and structured exposure to all of you, that how to be considered you're good in ultrasound in women's health, whether it's your radiologist, ultrasonographers, or you are doing it, or you're getting the report from somebody, they need to have almost good training in all these 14 components. I will highlight more on the 14th section. This is an ISWAP. It's very basic membership, around 50 pounds a year. But the amount of exposure you have, the learning modules you have, the videos that you have, the discussions you have, is phenomenal. It is far superior than, it's almost like a ministry of ultrasound for me. So please consider that whatever I'm going to say, some of it comes from this, because I cannot be good in urogyne ultrasound. I cannot be good in gyne oncology ultrasound. I cannot be as good as somebody else in reproductive surgery, laparoscopic, but I can always expose you to what is the minimum standard with which Europe is operating, Asia is operating, and states are operating, to consider them as a tertiary care providers in these two modalities. Let's not forget, whenever we are assisting women, let's take the women at least until 14 weeks of gestation. I do take up to 20 weeks because of my background exposure to fetal medicine and Royal College of Radiologists diploma in obstetric ultrasound. I tend to take women up to 20 weeks of gestation. So once you are within this structured umbrella, I will call it as Nalanda University in UK, at least in ultrasound. Why I say this? Because all over the world, people, almost 140 country people, have adapted these learning modules, and anyone can be member. And I will, if you have a specific interest groups, I will guide you how to get good at an ultrasound. And I'm encouraging anyone in Bihar to allow me to come and do hands-on training, 48 hours, 72 hours. We can scan 20 patients and we can go through each one of them. Obviously, the conditions in the women should be available for you to be good at it. Theoretically, whatever the presentation that I do today has some importance, but the key importance is somehow you need to allow me to, I should have access and to give you hands-on training. And I'm very confident that you can learn 80 to 90% of what I know, which I learned over 40 years in probably 40 hours, which is sufficient for primary and secondary care of ultrasound reporting and hysteroscopy procedures, both see and treat. So the framework is important. I'll be roaming in these zones, predominantly focusing on reproductive medicine. These modules are overlapping with our training. If you want to be trained qualified gynecologist in UK, and obviously which subspecialty you want to practice, you have to go through these modules. And we can adapt this to Indian Fertility Society. We can adapt to whatever organizations in India we have. For example, in Middle East, when I'm traveling here, I brought British Fertility Society accreditation of ultrasound. So we can always, the many Australian, American least, but European and Australian, I can accreditate your nurses in ART. We can accreditate IUI. You can accreditate surgical sperm retrieval. They can be accredited with British Fertility Society. So I take it very seriously. I don't want you to travel 40 years like headless chicken to learn what I learned in different countries. I want to pass on much more shrewder, smarter way of acquiring the skills and qualification and accreditation to have a credible say in your own community and convince the Indian organizations, Foxy, so that you practice at a highest level of confidence to the patient. Now, this is just a flip through. There are so much in the ISWAG website. In some of them that I'll highlight, but I want you to know the university, almost like a university of ultrasound in women's health. That's how I define ISWAG website. It's phenomenal and mind-blowing. They give you patient information sheets free of charge for you to download. You can convert them to any language. They're giving almost the clinicians input on ultrasound finding, clinical management, follow-up, pitfalls, false positives, false negative, so much of honest teaching that in ultrasound is exhibited. And also they're conducting so much of learning programs in entire Africa as we speak. Any third world country, anybody who wants to learn, they're raring to send their people. I'm an international faculty, so on behalf of ISWAG, I can come. So these are all the different learning windows you have that give us clinical output. It's just not an ultrasound. It is not a radiology training program. This is clinically relevant, meaningful programs. So I'm just giving you an idea. I have this ultrasound machine. When I do the module on urogynecology, when I put a probe on the vulva 3D, it gives me the entire levator outlet dimensions from centrum to the paramedium. It can give the details of descent. It can give descent of the dilatation of the hiatus. It can show me the avulsions of the levator, all within 20 seconds. Now, if I go to Alani Institute to learn all these skills, my professor will be in front of me, my senior resident, and then lecturer and tutor and pool officer. Me chance of learning as a PG student in the first 3 years of urogynecological accuracy was remote. Now, an ultrasonographer sitting in a urodynamics clinic in the OPD in UK or in USA can diagnose most of the pelvic descent abnormalities objectively within 20 seconds of multiplanar vulval scanning. So I'm just giving you the technology heights that we have reached or the scientific community has reached. With objectively, you can accurately demonstrate. And if in case you found there is a pathology and do any pelvic corrective surgeries, you can demonstrate your surgery. You have done overdone it. You have done less than you should be. You can verify instantly, which means post-surgical vaginal plications, bladder repairs, any single thing that we can always check post-corrective measures. Your surgery is accurate or you have overdone it, you have underdone it instantaneously. So that is the level of urogynecology thing, as well as the descent disorders, urethrovesical angle disorders. All of them take 20 seconds. There is a software in the machine. It will confirm whether, even if you don't know, the machine, the application specialist who sells the machine to you will come and educate you on this. So I want you to be investors of quality equipment. For every 100 people, let one be investing in the quality equipment and quality learning. Now, in this list of the modules or the learning methods that you have, as you know, if you're too busy practitioner, you don't have time to count every follicle. We have the Sonovac, which is an automatic measurement system. I rarely use 3D or all these fancy items, but I'm just saying to you, these are all built into the machine when you buy them. Just coming to, because we'll be discussing pain, whether it is infertility associated or not, or pain due to adnexal torsions. So any condition related to pain, particularly some of our discussion, whether you're practicing IVF related ultrasound or laparoscopy, you will be encountering endometriosis and adenomyosis. Please follow the universal standard guidelines on how to do diagnosis of endometriosis and adenomyosis, and how you differentiate management of the pain and management of infertility in an algorithm way. As I said before, I have 52 algorithms. Anyone who from this group of listeners wants to build your own guideline, your own almost like algorithms or just a handbook on infertility, including the data sheets, diagnostic and treatment programs and protocols, every single thing related to ART. I designed the book as a handbook that I will send as a PDF for you to print and put your own hospital logos and practice settings. You can use it. But there will be a lot of structured approach to them, and 80 to 90% of people can be managed with a structured approach. The rest experience come to play. You need to discuss with your senior colleagues or the experts in the field. Again, oncology, very rarely in infertility clinic, you will be overlapping, but I just want you to be aware, maybe some of you practicing these things anyway. I gave this green, amber, red for infertility. It is one of the slides you will see in due course, that where I'll be telling is that when I assessing a couple, she's green means, even if I don't do anything, she's going to get pregnant. And red means whatever technology that I use, they're not going to get pregnant, and we give them the alternate options. So the traffic light model I was following for nearly 12 years when I designed this algorithm's first version. So I'm glad to just say we have the similar user-friendly models of caring women in the oncology group also. So this gives the classification of ORADs. So time and again, you see ovarian cyst in infertility clinic, you cannot suddenly dismiss they're all functional cysts. So I like doctors who write differential diagnosis rather than they say they know what the diagnosis. I'm scared of doctors who know everything. So I like people. You always put differential diagnosis so that you are not, misdiagnosing a patient and mistreating. So just to give a glance of things in ultrasound, using ultrasound, in adolescent, you can do rectal ultrasound. I introduced this model in Dubai when I first came. People are doing abdominal scan because here, as you know, in a Muslim country, there is restrictions. I live in UK since 92. So it is more often than not, even if the unmarried girls, they have been practicing sexual activity, we could do TVS, where you get more information. The probes are nearly touching the organ. Abdominal ultrasound, the organ is far away from you. So using rectal ultrasound, particularly putting some saline in the rectum, saline in the vagina, and then putting a probe in the rectum will give you almost like a transvaginal ultrasound-like picture. Whenever we say ultrasound, almost you must guarantee it is abdominal as well as vaginal. The reason being, any organ which is close to the ultrasound probe will be depicted much better. We should not have dogmatic approach that TVS is superior. No, it depends on where the pathology is. You need to be close to the pathology. That is the ultrasound called correct ultrasound. It's not TVS, it can be TIS, it can be TRS. So overall, these are the conditions that we will be dealing with. That ambiguous genitalia, you don't need ultrasound for that. Sometimes we do need CT scan and MRI to rule out other pathologies. In precocious puberty, vaginal foreign bodies, you can always use it. In fact, we can use the pediatric cystoscope even in imperforate hymen to study the endoscopic foreign bodies. Masses, again, rectal scan will help. Again, we're talking about the people who have intact hymen. That's when these issues will come. How do you diagnose? So the conditions, you need to have this on the table. What are the conditions in adolescent where you need ultrasound and histoscope? What are the conditions that you'd use these two modalities in the reproductive age group? What are all the conditions where these two tools will be perimenopausally well utilized? That's the point of going through this theory. Once you know the embryogenesis of Mullerian duct and Wolffian duct, accordingly, you will know what can go wrong with them. And in reproductive age group, how a 3D ultrasound now almost replaced an MRI in diagnosing the structural abnormalities. But when you see them in the pre-puberty age group or puberty age group, CT scan and MRI still play a huge role. So we should not have a closed door approach for that. So this is just a list of things. You should keep it on your table. Normally, I have a habit, even if I went to join the Bone Hall, Cambridge in 2001, I had a huge table. This is an estate, 22-acre, estate in which the Bone Hall invented IVF. My room was big, and so there was a big table on which I put the glass, whatever, like biochemistry, steroid pathways, certain things, just to give an idea. When the patient comes in, she has pain during menses and infertility. I always think of multiple causes. One patient walked into me very tall after failed IVF. As soon as I shook my hands, I knew she was gigant. She had, pituitary tumor. So the approach to infertility patient, once I suspect growth hormone related problem, was totally different. So your general knowledge of pediatric endocrinology will go a long way in your reproductive medicine, reproductive hormones. So when I discuss how do you use ultrasound, how do you use hysteroscope, you need to know the interaction between the Mullerian duct evolution. There are two Mullerian ducts supposed to dissolve into one. I call two semi-detached houses. You break the wall in between, you make them unified. It's like two Berlin Wall broken, both Germany's uniting, something like that. If that doesn't happen, so the septum will remain, or it will remain as a bicoordinate uterus. So you need to aware of a little bit of embryogenesis of that. You should know how the vasculature gets distributed outside in the parametrium, at the level of cervix, at the level of parametrium, around the infundibulopelvic ligament, around the ovary. Whenever you're doing any procedures in the ovary or the tube or the uterus or broad ligament, you must be aware of this interaction between the vital organs, such as if you take ovarian fossa, whenever I teach ovary, how do you handle ovary safely? You need to know ovarian fossa, the structures. So without having surgical anatomy, it's very hard for you to be a good clinician to practice. We do come across non-gynecological tumors in the reproductive age group. Be mindful of that. Just to give an idea, I want to finish off the less common problems. For example, somebody is coming with pain. I just quickly go through either it is infection related or ischemia related or inflammation. These are the two things. I'll just go through. You all know how to use laparoscopy, how to use Doppler in torsion. Torsion grading being the mild torsion will reduce only the venous flow. Moderate torsion will occlude the venous flow totally. Much severe torsion will reduce the arterial flow, and much severe grade 4 twisting or torsion will stop arterial flow also. So depending on the blood supply, stagnation of the blood is the venous disturbances, and hypoxia related changes in the torted structure related to the hypoxia due to arterial changes. And most of them are combined. Accordingly, the lesions, what you see in a torted structure, will be very variable. There is no textbook. We are not MBBS students anymore. What are the features of torsion? So you need to graduate mentally. How do you use it? So I'm referring to my colleagues. I'm one of the international faculty. We have 133 people on the website. So I'm using my colleagues' work because 133 people are teaching me every day. And maybe I'm just learning 1 in 100. My role is into giving this information. There are 99 people doing similarly useful work for women for better diagnosis. So it is like a human body. There are trillions of cells working, but as a one body. So we need to have the body of knowledge, but there are so many people make a role. I'm sure you know how the ovarian torsion presents. Clinical diagnosis is the key. Variable presentation and ultrasound. These things are available to you on YouTube and the ISWAG website. Sepsis, you need to be aware of. Sometimes chronic abscess, chronic ectopics, you need to be aware of. There is no single description. Everybody should know there are 18 shades of white color. That means ultrasound. The more trained your eye is to identify these 18 shades of whiteness, the more authentic your diagnostic accuracy becomes. That's all you need to know. Sometimes, even just a normal corpus luteal hematoma resembles endometriosis or abscess. So you need to be mindful of that, even torsion. So there is a huge overlap. So please write differential diagnosis. Don't be dogmatic. Do the better test. If ultrasound is insufficient, go to MRI, CT, take senior's opinion. If you're in doubt, go to laparoscopy, because the timeliness of pain is important to salvage fertility. So I want to emphasize, don't sit dogmatically on a pathology, even degenerations of fibroids. You have no clue. When I got married to an army officer, because I'm not very disciplined, I'm married to my wife, an arranged marriage from Indian Army. So she was struggling, suffering dysmenorrhea from her puberty. And when she comes to UK, first 3 months, I have to take her to casualty during periods. Now, that's I'm talking about in my own personal life. She had multiple pathologies in the uterus, congenital as well as myoma and adenomyosis from teenage and polycystic ovary. Can you imagine that? I'm just happening. And their parents were doctors, but they were giving painkillers for decades. So just to say, you may think that, we know if it is severe, they will come. And if anybody with ultrasound can diagnose, that doesn't take place. I give it classic example, 75% of Australian women who have been told who need IVF to become parents could not afford IVF, did not do IVF. Government could not support them. That's 75% in Australia. How much will it be in Bihar today? Maybe 75 to 90% of people, they know what needs to be done. They're not doing it for various reasons. Same applies. They know good ultrasound will help them with diagnosis, a good hysteroscopy, good laparoscopy, but there is a huge gap between what we know as doctors or teachers and what is actually available to the patients. There is very painful gap between them. Although I'm trying to educate you all today, but my intention is that some of you has to take it seriously that we must introduce a pan Bihar ultrasound hysteroscopy training program. Pan Bihar. Okay. I want volunteers. Please do brainstorming meeting with me. I will work out how intelligently we can execute it. There are portable ultrasound machines nowadays because you cannot buy the expensive machine, and they are 70 to 80% useful in diagnosing most of the conditions. We have a review. A lot of people, they give pills for whatever they see at next cyst, saying you take the pills, this cyst will disappear within 3 months. Once again, there is enough evidence to say don't blindly prescribe hormone pills after you see some cyst in the adnexa. There is no evidence whatsoever for such blind approach. And there are less costly portable ultrasound machines. I know PNDT Act in India, you will all be thinking Dr. Karunakar left India in 92. He doesn't know how horrible the local politics are. You may say all that, but I'm aware of what's going. I travel to some different parts of India on almost every 6 months basis to train doctors in ART, hysteroscopy, and ultrasound. It's going on for nearly 5 years. So I'm aware of that there are training options available and open to. So this fertility, I will do a next presentation, overlap it, but there will be what I'm looking for, how it looks like, it should see. Therefore, I insist for you to have, says my internet is unstable. So some of you has to guide me in between that things are going okay. And I wrote a big book chapter recently. I will show what this presentation means. The entirety is this chapter is how an ultrasound will improve the outcome of monitoring ovarian stimulation. At this stage, I will just deviate a fraction just to show the book chapter. It's important. Anybody who WhatsApp message me or email me, I will share the entire book chapter. You don't need to buy the book, but if you're interested to buy, you can buy. But the point is how effectively on a structured template, you will use ultrasound to get the better outcome of whatever treatment you chose to give. And that's the point I'm trying to make here. This is Word document pre-publishing that I sent to the publishers. Nakul, if the screen is clear, whosoever is monitoring. Yes. Hello. Well, some of you can tell me internet is working well.
Yeah. The screen is very visible.
Okay.
We can
So
see.
this is the book chapter. It's a handbook on how effectively use ultrasound in those women where you're giving medication to stimulate ovary. The quality, what is quality? What is meaningfulness? I always very particular about glossary. Only that which can be measured is quality. It's not that what you know in your brain. Have you recorded? Have you documented that what drug you gave, what effect you got from that cycle? And the next person who is going to manage the next time will manage that case better if that is the case. If not, we lose the plot. So I need to know how the previous care was. So documentation is necessary. So I believe in only that which can be measured is quality, not that subjectively what we think. So what I have done is, how do you prepare, how the abdominal scan is no longer sufficient to get the optimal imagery of the ovary, not only for antral follicle count, underestimation, overestimation. I just depicted limitations of abdominal ultrasound versus TVS is the emphasis here. And I can show women when they come to me, I show it looks like a little black grapes. And this is a big black grape. There may be a seed or not. This is how the seed looks like live after the collection. And this is how the cumulus woofers looks like in a 3D. So I'm just giving you an idea that how my woman who sits in front of me, even before she comes, I can send this image to her. Look, lady, you have egg bags. Nobody saw your egg. Don't even know that every grape has a seed. They understand my language. So I use this kind of imagery, analogies, metaphors to not only with colleagues, but with the patients, so that they are in the loop from the beginning and they stay with you. The patient retention rate will be very, very high if you engage patients. Let's not treat patients as ignorant. A lot of people tell me, Dr. Karunakar, you keep on teaching so much biology to your patient. I believe they're human and there is only one Atma. And if I know something, they will also know something. It's an art. Even a 5-year-old should understand if you're a good teacher, whatever topic that you teach. And that's my knowledge from my 11 teachers that I use. My senior most teacher who is alive is 116-year-old in South India. So again, how the 3D technology has evolved. This is how the blood vessels within the cumulus, within the granulosa cell layer, theca cell layer looks like. This is the details that you can go these days with 3D ultrasound, just to give an idea where the technology has moved. And if at all you're going to monitor follicle, try to take 4 images in the screen so that you are not repeating the measurement of the same. You are not doing the right ovary, left ovary, again, right ovary, rotating the probe clockwise, sometimes anti-clockwise. There should be madness in learning, but once you reach a method, there should be method in your madness or madness in your method. So there is no duplication of measurements. You can see in 4 frames, you can get all the follicles in different planes of the ovary. So that is the point, saying how diligently you can use the physics of ultrasound machine currently available in good quality machines. They will make the errors lowest error. Technique dependent errors, technician dependent errors, which is inter-observer, intra-observer variations can be minimized, and documentation to prevent medical legal issues. The next clinician will respect you if you send a great monitoring report. We have to cultivate these habits. Clarity is spirituality. So we belong to Sanatana Dharma. We need to give clarity to our patients, our couple, and the next physician who are going to manage. When do you measure follicle in only single dimension? When do you measure them in multiple? Depends on the shape of the follicle. I gave example, inaccuracies. How much inaccuracy? 3 millimeter variation can happen, which means instead of getting a mature oocyte, you may be getting immature oocyte if you overestimated the follicle. Even this morning, somebody sends a case from India to come here for gender selection. Now, for whatever reason, they think follicles are big, but majority of the follicles were small when I collected eggs today. Half of her eggs were germinal vesicles. It's sad state of affair. We are overestimating or underestimating the follicle because there is no good guru when you learn follicle tracking in the most accurate way. So it is important at some stage when you go through this booklet, you will understand. As I said, I can freely share this book chapter with you all. You don't need to buy the book. Knowledge is not for payment. That's my thinking. Once again, you should know what is ovarian fossa, and then you build the knowledge of the ovary. And if at all you're going to put a needle, you need to know where to stop. So just to minimize the complications of the egg collection procedures, I encourage people to have a look at the images that I shared. So when I gave a template, I told you around 30 things I will see within 5 minutes. This is my first consultation ultrasound report. In this, I declared this lady need to go for surrogacy within 5 minutes of me ovarian PRP, ovarian stem cells, donor eggs, after scanning testis, putting a needle, checking clinically, I can say this test is 90% cannot create his next generation with his own gametes. So this level of detailed, authentic, robust assessment of the entire couple, I call it as one-stop fertility assessment service. That is what I designed. This I designed in London Women's Clinic way back in Harley Street, London in 2007. I kept on updating. So if at all I have to give you one gift, use this ultrasound template, put your own company logo. You can use it. You can do a brainstorming with me how to really get good at it. So this is the ultrasound reporting form. And I'll be telling people what you do at baseline, what do you do to bring menses on, how does, the previous history will dictate what drugs you use for stimulating ovary, every single thing. It gives an idea, but this is predominantly how do you monitor. This is my own audit in London Women's Clinic where I measured the baseline antral follicle count and I was wrong in almost half the time. Same applies to my ultrasound. I thought ultrasound is good. When I do hysteroscopy, I was wrong 50% of the time. So what I'm trying to tell you, this, even if you practice medicine for 30 years, the tools have limitation. It's not that you are incompetent. The tool has limitation. We need to be very, very clear about what tool is competent for what. Not that you've done hysteroscopy, endometrial receptivity, you're diagnosed. By doing ultrasound, you think you diagnose endometrial receptivity. Because you scanned the patient, you said she has 5 follicle and you're getting 15 eggs from her. Now you say she has 15 follicles in the baseline total, you're only getting 5 eggs from her. That is when you park your brain and then think and get good at it. That's called auditing. Measuring what you expected versus what you actually achieved is called audit. Then only you can start a research. Without searching what went wrong, you cannot do research. And you can't sustain what is good with you if you don't do research. So the random antral follicle count has huge pitfalls. This slide will explain. As I said, the technology MRI plane, if I'm scanning outer 1/3, middle 1/3, medial 1/3, the number of follicles that I see is much higher on 3D compared to 2D for various reasons. Everybody is going to scan from tomorrow. I'm going to ask all of you to practice bimanual scanning. Excuse me, I'll put the light on. I know I'm dark skinned, so I thought I'm very conscious. You can see me at least now. So the multiplanar, which is an automatic 3D, which takes anterior posterior view of any structure, coronal plane, will give you much more robust number without you actually missing the point. And the reason for that I'm saying is because of my own learning that I'm almost 50 to 60% of the time, I'm not actually predicting my own antral follicle count versus number of mature eggs I get. So this is my personal experience. Now, the difficult access to reach ovary, a lot of things, you think it is endometriosis, you land up in seeing lab, hydrosalpinx, you think it's hydrosalpinx, it may be adhesions. A lot of limitations are still there. Whenever there are compounding factors, you will use the appropriate laparoscopic technique. Don't rely too much on ultrasound is what point to make. Sometimes you will know you need to do transmyometric egg collection. Even on the day of consultation scan itself, you know it needs an abdominal egg collection. You don't need to really wait and not collect eggs because you're scared to put a needle through the cervix or myometrium or an unknown structure. I know I face this all the time, particularly if they had multiple egg collections, previous pelvic surgery and so on and so forth. You may have to travel through even myoma sometimes to collect a single egg going to give her a chance for pregnancy. So, and sliding sign means every stroke as one because they are super glued. So this is 3 follicles. And when I say there are features of blood, a blood that is collected within 1 minute ago looks different than what is collected 1 week ago, what is collected 6 weeks ago. You can put 4 differential diagnoses. One day you can call it as papillary adenocarcinoma. Another day you can call it hydrosalpinx. It's just a blood clot, resolving. It's like a plant sapling becoming a plant, plant becoming a bush, bush becoming a tree, and so on and so forth. So please be aware of the natural evolution of physiological changes of ovary and pathological changes and gravely pathological changes. You need that basic knowledge in your head of theory. What mind doesn't know, I will never see. If you don't do good ultrasound, you cannot diagnose patient, you cannot select patients for hysteroscopy, laparoscopy. So if you are not doing this much of diagnosis, the chance of you helping a couple to become parents is very small. I just want to share this particular picture here. If you are doing laparoscopic surgery, this is endometriosis. If you're trying to pull the ovary or the cyst from its 6 o'clock or 5 o'clock base, it's already spread out. It will recur at this place. If you are going to pull it somewhere between 12 o'clock to 5 o'clock, this is omentum. There is high chance you're going to perforate the bowel. If you're going to pull out this chocolate cyst between 9 o'clock to 12 o'clock, you're going to destroy her AMH and remove the only foreantral follicle she has. Now, I guide my laparoscopists by doing a 3D before they touch the patient, what they should do, what they should not do my patient. If I suspect my laparoscopic surgeon is a gynecologist, not a reproductive fertility enhancing surgeon, I will not use him. I don't want operation successful, sterility achieved. You understand sterility? Permanent absence, permanent loss of fertility. So I don't want any reproductive surgeon, whether it is hysteroscopic surgeon or a laparoscopic surgeon, to remove the fertility, to sacrifice the fertility and achieve a success. He removed pathology. He thinks he is a great surgeon, but he just induced sterility. Not acceptable. I'll use better surgeons. So by just a 3D diligent, the technology offers you the rendering. You spend around 1 to 2 hours after the 3D image takes. You ask any MRI surgeon, MRI expert, they will tell you how efficiently we can guide them. Like an MRI, for me, 3D is like an MRI. So I spend a lot of time, not just 20 seconds, the standard image that comes. I spend 1 to 2 hours to get this kind of pictures. It's like you make a Ganapati. I'm very fond. I like making things with my hand. So when I make a Ganapati, within 5 minutes, I can make something. But after 5 hours, the finishing touches that I give to the same Ganapati is much more fine. That's all I'm trying to tell you. You spend more time in learning whatever skill you do. And you need to be, out of 100 doctors who are doing ultrasound, one has to be the guru. There's no way. We need gurus for every 100 gynecologists in ultrasound and hysteroscopy. We cannot have one in a million, one in 100,000, one in America, one in there. No, just our women needs us to be expert. We can't just say you go to another clinic, they will look after you better. And that's why people run away from their own doctors. I use a lot of templates. I'm driven by structure and system. I live in UK since 92. I didn't have a system in central institutions where, including AIMS, that I was there. It was a kiosk that I became a PhD in kiosk in AIMS. And I just need to undo myself. It's like, if you're driving in Delhi for 20 years, you will fail driving test at least 2-3 times when you go to UK. You never drove in India. You just learned driving. Within, 4 to 6 driving lessons, you will pass the driving test. So it's the same thing. Jivatma, which is in Maya, it takes a lot of time for some people to come out of Maya. But there are people as a child, they maintain their childlike curiosity and creativity. They're always spiritual. They're always willing to learn. And these are the people who are doing greatest work in many countries are the people who are childlike heart with curiosity and creativity prevailing in their head all the time. They don't have baggage of pain of the past, failures of the past. They don't have baggage of fear of failure in future. There's no anxiety. So I will call them Mrityunjaya Vidya, specialists. So I have only 2 templates for you to share. Mild stimulation algorithm, where it's like a partogram. There is an action plan. I'm sure you know partogram. You're using action plan in labor room. Somebody who goes on 90th centile, the trajectory of the follicle, somebody goes on the 50th centile, somebody goes on the 10th centile. So I classified people into A, B, C, D category. A being the quick responders. From stimulation day 8 itself, the follicles are all, crossing 20, and they already had LH surge. So by the time you go and collect eggs, they're already ovulated. You don't know because the polycystic ovary is a moody ovary. They don't talk. I call it as manic depressive psychosis, MDP, which means they never talk. When they talk, you can't stop them. Something like that. Sometimes they take 21 days to respond. When they respond, there will come a flood. Sometimes on day 8, everybody is ready. They're just running in a stampede. So please be aware of that. 60% of your patients will be polycystic ovaries. So when you use an ultrasound template, you should have a trajectory. So this is a self-explanatory. This is a modified design from Care Fertility. I used it, but I did a lot of modifications to bring my own version. All of you can use it. So I use 2 templates. One is mild stimulation for IUI or timed intercourse. And the other one is hyperstimulation algorithm. Okay, 2 folliclograms. It just gives you different trajectory because you are forcing them with a high dose FSH. Last but not least, I just give examples of how you learn from the mistakes from other clinics, but you need their follicle report. Again, if you have 3D, you'll reduce, if you're a busy clinic, it can reduce you assess endometrium in this, where endometrial waves, myometrial waves, are the commonest reason for abnormal estimation of endometrium and false overdiagnosis of adenomyosis. That's the point I'm trying to make in these pictures. And I do saline contrast scan very regularly to assess the endometrial normality. I will share that in a minute. And there are videos on egg collection so that how to safely to do it. This just almost covers the ultrasound role in ovarian stimulation. So I just detoured a bit from here. So I will close this Word document. Whenever you want a little break for coffee, because I already hit close to 70 slides. Maybe you haven't recognized it. That's what has happened. So this is the book. I don't know the price in India. It's just how do you, in a systematic way, as endometrial assessment. I use standard water or distilled water or saline or uterus to give a black contrast to the gray tissue. That is for uterine cavity and endometrial assessment. I use saline. And then to assess the fallopian tube, I use the air contrast. The original being in Allen Institute, I used to do air insufflation tubal patency test. Trust me, 6 years I was in AIMS, Delhi. I used to connect Rubin's cannula, connect with the blood pressure cuff, pump it, put a stethoscope here on the left iliac fossa, right iliac fossa. So that's how I used to diagnose tubal patency test, right? And that's why I got MD. Nothing else I've done to get my MD from AIMS. So that's just to give an idea. But then that moved on to the ACOSI that I myself discovered that human albumin has very high density. We use for sperm wash media for IUI preparation and also the oocyte incubation and even embryo culture. All of them has the human albumin because fallopian tube has a rich in albumin, which is a high density liquid. High density liquid traps air if you force and agitate. So I found out trapping air in albumin gives the air, and air almost reflects every ultrasound back. That's why you see white color. Anything that allows the sound to go through looks black. Anything that allows every decibel of ultrasound that you're sending throws back, the echo means returning, then it looks the whitest, like a bone. So I found air is the best. So I use the word air contrast salpingography echosi. I will share that with you in a minute. So that's about contrast. One is tissue contrast, other is liquid contrast without air, third is air contrast. You can use 2D or 3D. So if you're assessing myometrium, you need to follow the international classification of slightly changed from whatever you must have known palm coin. So I just giving you an update knowledge. Maybe you already know all these things working in teaching hospitals. As I said, my lecture is not, it's just rather blind. I don't know the level of intelligence of the listeners, complete spectrum of listeners. So I just randomly throw some slides at you just to say where we are practicing medicine in ultrasound as of 2024. And this is how you classify myomas. There is a sub-classification of texture. This is how we classify vasculature, normal vasculature, and vasculature of pregnancy, vasculature of implantation, vasculature of placenta percreta, increta, vasculature of AV malformations. So that even with addition of myometrial assessment, you assess the vasculature to enhance your diagnosis. Now the palm coin is gradually being replaced, palm and a coin, it's been replaced into MUSA, that is morphological uterus sonographic assessment. Doesn't matter, you need to follow one format. If I give this to my professor, she will laugh at me, Karunakar. You are always been mad as a resident, even now you're about to die, right? Even now you're mad, right? I do my hand to diagnose fibroids. I do my hand to do myomectomy with my laparotomy. My professor will tell me today, my hand is better than endoscope. My hand is better than ultrasound, 2D, 3D, 4D, and so on and so forth. I respect my gurus. They made me what I'm today. But, I just want you to be aware of everything what is available, but you do what is relevant to your patient to maximize the diagnostic accuracy. You don't know to ape any other person. You don't need to copy anybody, but you should have the beautiful amalgamation of all the knowledge, seep it in, sink it in, synchronize it, which is Shravanam, Mananam, Nididhyasanam. Then the knowledge will come out of you as action. You will do greatest action if you go through all this structured learning from appropriate teachers and appropriate knowledge base. So whatever simplified assessment useful for clinical practice, it is already in my ultrasound template. So I'm just saying, whichever way you go around, you don't need to copy somebody what is done in UK, what is in USA, but you should help the patient in front of you. It is not about copying European nomenclature. That's not important. That's not relevant. We pay a lot of attention to the junctional zone because once you break the roots of basal endometrium, you penetrate myometrium, you are heading adenomyosis or invasive carcinoma. So you need to know what is junctional zone, where the basal endometrium and the deepermost, innermost layer of the muscle layers, how they look like in 2D scan, 3D scan, you need to practice. Once you practice, you know when you lose the barrier between the two. It's almost like a blood-brain barrier or the brain sperm barrier in the testis, whichever way you look at it. There is still selective role of measuring uterine volume and cervical volume separately, particularly in oncology, and power Doppler has a significant role. Adenomyosis, once again, if you see non-homogeneous myometrium without distinctive outline, you must think. There are greatest surgeons that I work with in UK in many, many parts. They think it's adenomyosis. They go inside. They come up very easily because it turns out to be fibroid. They enucleate. And they go sometimes thinking it's the myomas, but they land up in doing hysterectomy or incomplete surgery because that turns out to be adenomyotic lesion. Now, 1/3 of them have both adenomyosis and myoma. Then still they can have uterine malformations also. And if you're going to damage endometrium, thinking by removing myometrial pathology, you're going to make her more fertile, but you'll end up in damaging endometrium because of the heat surgery, because of devascularization of endometrial basal endometrium. Again, you are not allowed to practice ART. I'm sure some of you have seen in endometrium goes like an S shape. It's just one of the criteria. So if there are 2 out of the 6 criteria is met, we call them adenomyosis. This is self-explanatory. Please try not to write down or remember, or, we are not undergraduate students or elementary school. This presentation, more than happy to share with each one of you. Then spend time, keep it as your backdrop, read it again, go through all the rigors of your sinking everything into your mind. So I just slide slowly into abnormal bleeding, which can be a presentation to ART, or without treating abnormal bleeding or improving endometrium, imetrium, you're not going to succeed. You can always collect eggs, create embryo, do the genetic testing, so at least you can secure fertility, but you cannot ensure the pregnancy unless you improve the myometrium, myometrial blood supply, endometrial integrity. You must understand this, right? And recurrent implantation failures are preventable. Recurrent miscarriages are preventable to a large extent. And people classify them as unexplained infertility, unexplained recurrent miscarriage. I call them unexplored recurrent miscarriages, unexplored infertility. And there are reasons for this. There is an evidence for it. So whenever there is an abnormal bleeding, you know the conditions that cause, you know an ultrasound, what role it plays, how a 3D will play, how the contrast scan will play a role, how does blood supply to that area will play a role, how does hysteroscopy play a role, how does the laparoscopy play a role, how does MRI, CT scan play a role, how does your senior, who is dedicated entire life to use his experience to help the couple, marrying with the modern technology, marrying with the current knowledge as of 2024 guidelines. Every year, there are 40, 50 people all over the world, the gynecologists. They spend their 30, 40 years non-stop into just work with one condition, how to study endometrium. Trust me, this is the professor, Brussels person. If you see this blue color slides, this is the only one that I've took it from. He is an ISUA colleague. So we share slides. So I'm deliberately using his slide to say how endometrial study is taken into. He has got entire presentation. Anyone interested? I can upload his video, or I will see. As I said, if you join the membership in ISUA, you can see how you can assess the endometrium, endometrial blood supply, and pick up benign condition, hyperplastic condition, and then malignant lesion, as well as how it will affect the fertility. You need to have this kind of a condition-driven approach. If you do see cavity fluid inside the uterus, we have different approaches that compresses endometrium, that can represent other pathologies, and so on. So you need to pay attention to, if you see my ultrasound template, there is a structured approach to every single detail, but I'm giving an evidence. I'm giving other colleagues in Europe who are spending 30 years doing only this thing. They're not doing cesarean section hysterectomies. They're not doing crazy egg collections and embryo transfer all the time. You need to evolve science until we are drop dead. We can't ask somebody else to produce evidence all our life. In our life, out of 100 gynecologists, wherever you are, we need to produce evidence. We need to contribute to the science. It's not somebody else's job to produce evidence and we just make money out of it and forget about it. It's not on. So I encourage people that out of 100 gynecologists, one has to do the greatest possible research in ultrasound and hysteroscope. That's my appeal to the people. Once again, how the Doppler can be used on its own. There is 2 days lecture on Doppler of myometrium and endometrium. Trust me, that's how this current level of understanding of value of Doppler. I'm sure you all know value of optic Doppler. I'm sure you know value of Doppler in oncology. But now Doppler in infertility has a small role. In my infertility slide, I will do that. So at some point, the moderator of this meeting has to tell me, if you want a little break, I will give a pause. Then I'll go to directly to some of my cases in infertility. The second half of the ultrasound lecture, and then I will straightly go into straight single lecture on hysteroscope. So when I'm saying female, I just want to touch base. I do deal with male also. I'm a male reproductive endocrinologist. I do micro TC, I do teaser, PISA. I don't do varicocele surgery or penile implants, but I'm sexologist in the sense I look after males. So out of 100 of your gynecologists, please, one of you should become very good in erectile dysfunction or ejaculatory disorders. You know why? You cannot neglect just because you're a female, you can neglect. I'm a male gynecologist. Female allow me to do it. I'm sure if you're damn good in andrology, in what you do, men will come to you to be treated. So let's, put aside the gender of a physician as an indication not to be good in As I said, within a single day, each one of who are listening to you, I'll make you do PISA, teaser, micro TZ, no doubt. Single day is enough. We'll do 3, 4 micro TZs together. You'll be good at it. You will know how to mail examination. And this is what I want Dr. Shashibala to allow me, or anybody for that matter, whosoever is in the think tank. You want to help your own, the workforce of gynecologists to be damn good in ART. I'm more than happy to come and train in-house. And I've given the details to Dr. Sheshibala, who will be happy to share with you what is the structure, how to go about things. And again, in male factor, first you should know what you're looking for, then ultrasound will show you. Otherwise, it's no point in picking hysteroscope or ultrasound without the theoretical knowledge. So we're very particular about vascular pattern, but some senior professors say, no, I'm not bothered about Doppler. I know this condition by just doing a scan and hysteroscope and laparoscope. That's okay. But, we're talking about the ISOAC standard, teaching hospital standard. And there is a teaching hospital consultant faculty in Bihar. So we must provide academically excellent diagnostic workup sheets in every geographic location of India. We are no inferior to any country. Therefore, I want to emphasize, let's bridge the gap that exists as of today. We always give patient information sheets. I have in Care Fertility UK, if you come to consultation room, I have 32 patient information sheets. How the ultrasound will be done, how the IUI will be done, how the man should prepare for semen analysis. It can be in multiple languages. You go to nhs.go.uk, you will see 32 language, including, Gujarati, Punjabi, Malayalam, Telugu, Tamil, Urdu. There's so many multilinguistic patient information sheets are there, videos are there, still images are there. So more visually patients connect with you, the doctor's infographics, it will make people engagement with you. The once couple are engaged with you, say, for example, you declare Dr. Karunakar is working with your clinic. I'm offering you this. You can consult free of charge your patients and you on a given day with your complex miscarriage case or infertility case from today. That's a promise. So let the gaps disappear between so-called the tertiary centers of infertility or hysteroscopy or ultrasound centers versus your own center. But we all have primary care setting, secondary care setting, tertiary care. I'll be showing the technique of saline contrast sonography to delineate the pathologies better in the uterine cavity. And oncology, I will just restrict. It is very important. There will be cases where you think it is just an endometrial polyp, but by seeing the further details, vasculature, surface, echogenicity, heterogenicity, the more knowledge you are, the more stratifying your brain in delineating the features. Adenomyosis looks like that. Sometimes endometrial carcinoma, myometrial invasion also looks like that. But there is a way to differentiate the two. And last but not least, let us say you finished adenomyosis, myoma, endometrial pathologies, polyps, and you're damn good at it. And structural anomalies with 3D. Then comes perimenopause. We do see patients now. My oldest mother is 58. And between 40 to 45, regularly people are knocking on your door in their second marriage or the children died. For whatever reason, you do come across people where the ovary is saying, I'm retired. Uterus is saying, I'm about to retire, but they want to be parents. You must not say you're too old for this. Never. Never ever sell our own biased opinion to anybody because somebody other than you might have a better approach to that condition. Patient has a right to live until she's dead. Patient has a right to be happy until she's dead, or the couple, and they want to enjoy the parenthood no matter what their history is. Our bias should not influence our practice. So I'll just quickly touch base how the heavy menstrual bleeding in the perimenopausal group has to be distinctively approached by saline contrast scan. And I'm showing evidence after evidence. How do you manage all of them in infographics? Keep this library of this kind of slides with you so that even if you're sitting in a small clinic, wherever you are, you don't have a stethoscope, you don't have good 3D ultrasound. This is with you, which means the knowledge is with you. Knowledge is everything. You all know Bhagavad Gita. It only says knowledge is the ultimate spirituality. And there are training courses on almost every week throughout the world on any aspect of ultrasound hysteroscopy use in clinical practice. As I said, you are a GP, we can make you a physician skilled in ultrasound. If you go to UK, the entire healthcare budget in UK is given to family physicians. You may not believe or you may know it already. So people buy gynecologist or a specialist service by paying them money. It's almost like a vendors. Specialists in UK are vendors. GPs are owners of the healthcare budget, which means the GP can be andrologist, a GP can have hysteroscopy license, a GP, family physician, can have an ultrasound license. In other words, when I went to UK, I introduced nurses to do IUI, but British Fertility Society accredited. Just to tell you, relax you, because I've been talking non-stop for a significant time. A professor from Delhi, Maulana's Medical College, she was in AIMS with me as assistant professor. She was my assistant professor. She moved to MAMC, Maulana's Medical College, Delhi. She came to UK on a deputation. She was pregnant. A midwife delivered her. Can you see the nightmares this consultant professor obstetrician from Delhi undergoes vaginal birth by a midwife in Kent? Panic. She thought she's a professor. The president of Royal College should come and deliver her. But the argument in Britain is, if you're a low-risk mother, low-risk fetus, midwife will deliver you at home in water. Take it or leave it. I'm saying to you, the stratification of the prognostic criteria of the couple is the key driving force. Hello, somebody wants to talk to me, interact with me, or am I continuing? So you may think, what is screening test? What is diagnostic? You all know. Asymptomatic people, you pick up a pathology. So screening normal women to identify at-risk people is called screening test. Confirming what is screened is called diagnostic test. You all understand. So specificity is what screening test is looking for. Specificity means test's ability to identify normality. Sensitivity means test's ability to identify abnormality. I asked this question in Viva. I'm an examiner for any doctor coming to practice in UAE for consultants to come. So I ask this question. I rarely get simple answer. People give me half an hour essay answer when I say what is sensitivity, specificity, because medicine is simple, but because of we get contorted and confused. So perimenopause asymptomatic, perimenopause symptomatic, perimenopause heavily symptomatic. Your approach using scan, contrast scan, 3D scan, hysteroscopy, CT, MRI, you need to diligently use all of them. So there are a lot of articles on how good the saline scan is, better than a normal 2D scan, how good the 3D contrast ultrasound scan is better than 2D scan. And once you reach, you go to guidelines again. Please put all this on your table. Follow the guidelines, follow the formula, follow the algorithms. Because every year, these people, 40, 50 people who spend 30 years doing only saline scan, 30 years spending reviewing the evidence, should be the better gurus or better teachers rather than we writing our own protocol because I'm a very senior consultant gynecologist. I know everything. So I have that problem in many, many large part of people. Once they become doctor, they're doctor forever. Trust me, I get assessed every beginning of every year. I get appraised at the end of every year so that I'm allowed to be a consultant in UK. Every year, if I don't pass the test with patient feedback, with colleagues' feedback, with 360-degree assessment, I'm not allowed to practice as a gynecology consultant in UK the next year, which means quality, which means you need to verify your credibility each year, year after year, until we say goodbye. This is a classic example, menopause.org.australia AU. Phenomenal amount of video literature material is available. How do you manage abnormal bleeding or infertility in the perimenopausal age group? In other words, these are all the information sheets, guidelines that can help patients or practitioners. So I'll give a little pause to this half of the lecture I thought, which is like a 1/3 of my today's webinar is completed. I encourage if anybody want to interact with me for 5-10 minutes, having a coffee or water, then I'll go to ultrasound. Direct, just ART specific ultrasound. I know I have given a hint, but I'll just go through some videos of tubal patency test and so on. If that's okay. Who is moderating me? Normally there is a moderator. Is that Professor Anita? One of you?
Yes,
Otherwise,
yes.
you'll be here until midnight.
Yes, we are all here, listening to you. Okay,
So how is it?
mesmerizing what is going on. So I'm very much
How is it
interested.
going?
Yes, we can have 5 minutes break because it also must be done also. I think we can have a break for a few minutes, 5 minutes or something like that. Then you can start with your next part of the presentation.
Yeah, according to you, am I making sense? Is it meaningful way I am taking things forward?
Yes.
So I'll start this in about 2-3 minutes. By the way, this is an embryo, gestation sac and yolk sac 4D, just to leave you curiously. Nakul, you want to tell me how many are listening? Sorry? Nakul? Can anyone tell me how many are listening live?
145 people are there online, and on live we are in this hall we are about 20.
Yes, I see the hall. Okay, to restart.
Yes, yes, we are there. I think we can start now.
Right. So thank you again for such a larger audience. Without student, there is no teacher. And without a patient, never ever there is a doctor. So it inspires me this time on a weekend. You're all doing it. So this is predominantly focused on how, with the least possible time a couple spending with you, you maximize the diagnostic information. So it's part of the one-stop fertility assessment or one-stop infertility assessment package service I do. And because infertility includes assessment of uterus, I can call it as one-stop uterine factor assessment service. I introduced this concept when I joined Bone Hall, Cambridge in 2001. They said Indians are always crazy. They want to do crazy things because Cambridge, they have their own base, you know. I said, I want to add uterine factor instead of just forcing a boy into girl's bedroom called ICSI or doing a, you know, arranged marriage called IVF. So what about uterus? They said, we don't have service. So I introduced what is called uterine factor assessment service for implantation failure in Bone Hall, Cambridge in 2003. That's where a lot of information came that almost a third of the implantation failures are preventable, which is a heartache. You know, if IVF fails, you almost given up everything. There's no light at the end of the tunnel. So my intention was, without assessing uterus, you should never do IVF or IU in the first place. Because if the soil is damaged, why do you go and buy the plants? Why do you create a crop without the soil being verified? You don't do that. So it's not a common sense as a farmer to do that. There is no soil. You're not looking to go buy the trees or plant saplings. So when I introduced it, then we realized 1/3 of embryo transfer should have never been done in the first place. And that is the unraveling of the thing. And then it opened the doors for research. So I'll share my experience at Bone Hall of starting one-stop uterine factor assessment service, which is a combined service of ultrasound, contrast scan, hysteroscopy, histopathology, all together. Because we are associated with Addenbrooke Hospital, Cambridge University, we were doing implantation markers, LIF, all that research were done from 2001 onwards. So this is a gestation sac, what you see outside, what you see as a bump here, that is yolk sac. The fetal pole hasn't happened yet. This is the level of details that you get. You can say, why do you need all this information? Rightly so, you don't need it, but I'm just sharing this $83,000 ultrasound machine that I use, what it is capable of showing. So this one-stop infertility service or fertility assessment, which means there is a boy and a girl, or there is a lady and a man, they haven't experienced infertility, but they're apprehensive of their fertility. Or there is a girl, she wants to know, as a boy who has some indirect markers of erectile dysfunction, volume of sperm is not good, he doesn't have libido, he's about to get married as a girlfriend, So fertility assessment is before you experience infertility. We do combine together, even home semen testing kits are available. We all know people are using apps for everything, everything they're using apps. So these day and age, you must open doors for fertility assessment instead of waiting for infertility assessment, because it may be too late for a girl or a boy. The marriage will be at stake if you waited. So a lot of conditions that you can identify after the marriage can be identified before the marriage. A lot of conditions, almost all the conditions that you identify after the marriage or after 2 years of infertility can be diagnosed even before marriage, so that you can save the marriage from breaking in the first place or from occurring in the first place. That's what I meant. I believe in the greatest success of any clinician is the authenticity and the diligence he takes the history or she takes the history. So I will share templates of this. Anybody interested, I will share the booklet. You can put your own logo and use the template. It gives an exhaustive amount of history taking before I consult. As I said before, I'm doing free telehealth last 5 years. I don't consult people. I do a Zoom consultation, step one. Prior to that, they may share all the previous tests, so I know what it is. And they share the hysteroscopy finding, laparoscopy findings, ultrasound findings, semen findings, previous surgery notes, previous embryology details. All of them is with me. I just take 10 minutes to review. Then I go straight to the expert opinion or a second opinion or third opinion. Okay, you can do that. If in case you want to assess them, I only call them in the mid-cycle. Why? I will explain. It gives the maximum possible information about the fallopian tubal swelling. You can do tube test. If you already instruct them not to conceive, you can call them and follow. And obviously, you assess the tubal pain normality, uterine blood supply. You've done all that. And in the man, you assess the size of the testis. You felt the vas. You can take fine needle aspiration under local anesthesia. As house officers in Tirupati area, where I was a medical student, 1979-85, in Venkateshwara Medical College, I did MBBS. As house officers, we used to do vasectomy, man standing, outside the primary health center, of course, within the campus. We used to do, just within the vicinity of primary health care center, we used to do vasectomies, almost 10, 15 every week as house officers. Man is standing, putting on a stool. I'm giving local block with a vinyl black thread. We used to make an incision, tie the vas, and give him 5 kilos rice or some dhoti because he succeeded in stopping further production of kids. And we used to do with the lapricator almost 70 cases of lab sterilization per day in massive camps in schools. So from 82, I've been stopping people producing more children. From 2000, I'm desperately trying to make more children or children from those who don't have a single child. Whereas, why I'm saying this, you can assess the testis, you can take a sperm sample from the testis, you can feel the vas, you can assess the Doppler severity of varicocele, you can assess infection. Of course, you have done a blood test. Trust me, endocrine report are spit out by a biochemistry machine within 20 minutes. If you invest in quality, within 20 minutes, you will get the entire hormone profile report in front of you, except AMH. I don't use AMH. If I see follicle 20, why do I check AMH? So for me, male complete assessment of pituitary, hypothalamo-pituitary testicular axis, including manufacturing, transport problem of the sperm, all can be assessed in a single visit. Please, 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 a place like where you are practicing, the least number of visits, the maximum information and assimilation of the information, and open the treatment options. All can be done in a single visit. And I encourage all of your gynecologists to become embryologists. Take another 6 months. You spend 6 years to be a gynecologist, another maybe 16 years to be a damn good gynecologist. Spend 6 months. It's extremely straightforward to learn embryology. I'll ask you to do MSc online and then do the embryology. Learn. Once you are good in embryology, you are unstoppable hero of or heroine of ART practice. Once you depend on some so-called cowboy-like embryologist who don't see the tears of infertile people with failed IVFs, you think you're producing a good egg, आपका अंडा अच्छा है, आपके embryos अच्छे हैं, मां नहीं बनते. You are just making them more depressed than where they started with you. I have seen people talking about आपका अंडा अच्छा है. They are only showing follicle, but they say अंडा अच्छा है. That is a nonsensical language. They put an embryo which looks pretty without doing the strength of the embryo, then she doesn't get pregnant. Her depression intensity is much worse. You're putting a blastocyst, 60% of blastocysts are chromosomally abnormal. you think you're putting a good embryo, please don't use loose language when you talk to the patient. So I strongly encourage people, you need to become a smart practitioner of the language. Shabdam is everything. Pada, Artham. We all know Pada, Artham. Artham is Shiva. Pada, Shabdam is Shakti. We need to use them so preciously, so divinely. We should not say at all. When you say it, it must be almost like Vedam, which means you are damn good in what you assessed, and your diagnostic accuracy, your treatment options that you open, all has to be at the highest level. It's possible. I can teach each one of you. Keep in touch with me. That's all I can say. Keep in touch. I've been doing the same thing. I have 4,600 doctors database. And this kind of training that I've been doing, almost 29 training programs I've done. I just came back from Pakistan with 3 days, high intense hands-on training in ART, hysteroscopy, and male infertility. Morning 8 a.m. to night 10 p.m. So if you want to see a mad ART person, somebody is speaking to you right now. Once I do this kind of male and female assessment in one-stop fertility assessment, I reach a point of ascertaining them, what it is. I just put sound because for me, Omkar, sound, Dhani, sound, ultrasound, everything same. I work on spirituality, science of spirituality, science of women health. For me, everything is same. It's just the sound. So for a sound mind, ultrasound is a potent pointer. Pointer means lingam. Lingam, okay, to health, which is specificity, or health, which is sensitivity. So your ultrasound, your hysteroscopy can be used for specificity, which is normality of pelvis, or sensitivity, the abnormality of the pelvis. In contrast, we see more of the same. I designed this word. Can you see here? There's white shadows, and there is one white here. I want to share. How many people see? This whiteness has got 18 shades. I'm not showing the bottom end. It becomes black. As you can see, the brightest and the blackest. Blackest means all the investment of ultrasound you are throwing at is gone through the tissue or the media. Or you threw 100 balls, all 100 balls came back to you, which means you get all the investment back. That is the whitest. That's all you need to know. So in contrast, we see more. This is the cobweb in my garden in Cambridge. This is the view of the road lanes from Burj Khalifa. From the known to the unknown. Jivatma to Paramatma. Antarmukham. So I use tissue contrast. I use liquid contrast. Liquid being saline, distilled water, albumin. Gel. Gel is $200. I don't know how much it is. Maybe 16,000 dirhams, 16,000 rupees. So please don't bother. Expensive. You can use sperm wash media for a contrast. And I use air contrast for tube. Obviously, I use 2D, 3D, and combination. Now, ultrasound reporting should be two. If you go to ISOAG website, whether you are reporting pregnancy, first trimester, basic first trimester scanning, detailed first trimester scanning, basic second trimester, advanced second trimester scanning report, and so on and so forth. Like that, I call it as what must be seen is called basic. What can be seen is your senior. So for every 10 doctors, there should be this mixture. Not everybody does basic. Then the women in your area will be underprivileged for the rest. So seeing right shoulder, right view, this is left sagittal view. This is right sagittal view. This is superior inferior view or axial view. This is inferior superior view. You're seeing the cut section, caudal view, that is axial view, or you are seeing the anterior posterior view or posterior anterior view, that is coronal plane or anterior posterior plane or 3D plane. That's all. Anterior posterior view of the chest X-ray, that's the fundamental teaching we all had in MBBS. Anybody of my age group, they will know that is the only X-ray we used to do. Once again, with an anterior posterior view, I'm just showing liquid contrast. This is again another yolk sac with gestation sac. I will leave that aside. We have already seen that one. Now you can see the anterior posterior view here. There is a gestation sac in the left cavity, septum in the center, complete septum. Right part of the septum is empty. Fundus is not dented, which means this is septum, not bicarbonate. Then the 3D, it will show the gestation sac. It shows the fetal pole. It shows the shrinking yolk sac, and there is no fetal heart. We all know there are guidelines of what beta hCG level, what gestation sac you should see MSD, what MSD you should see the yolk sac, and what yolk sac size you should see fetal pole, at what fetal pole size you should see fetal heart. Please stick to the basic, and your ultrasound reporting should system there. Why I use this example here? The liquid, the fluid within the gestation sac works like a liquid contrast. Now, what you're seeing here is this view. Imagine that this is the center, and this is the left tube of the patient, and you are seeing from the front of the patient, this is her left tube. So at 3 o'clock, I'm filling the endometrial cavity with air in a very slow motion. The air is 5 ml of air, 5 ml of albumin. I agitate, make a froth, like cappuccino coffee froth, just a froth, or surf along the seashore, you see. Then that foam goes through the inner lumen of the fallopian tube. And if the fimbrio-ovarian alignment is good, it will do palabhishekam. You understand Hindi, Sanskrit? Palu means milk, abhishekam. Yeah, you're pouring over the follicle. So perfect fimbrio-ovarian alignment is essential for spontaneous conception or IUI conceptions. All right. If it is not there, ovary is somewhere, fimbriae is somewhere, that patent tubes is meaningless to the couple. So just to say patent tubes, that's why you call unexplained fertility. Ovary is somewhere, fallopian tube is somewhere. You're not actually diagnosing correctly. You're using a loose term called unexplained infertility. So please watch how the air moves through the fallopian tube, provided you are not brutally painful. You don't put tenaculum, you don't put valcellum, you don't do uterine dilator. Just use a soft hands, use a small plastic HG cannula, pediatric Foley's catheter to go in, and slowly distend 2 to 4 ml of air. Wait for the peristalsis of the fallopian tube to allow the opening of the ostial end, allow it to gradually flow and spill over the ovary or the follicle. It's all in slow motion. It should take 10 minutes. The peristalsis may occlude the medial end. So you will deliberately declare tubal block because you are forcing when the tube is not in the peristalsis. What is tuber peristalsis? It's an extension of junctional zone contraction. What is junctional zone contraction? Endometrial peristalsis. What is endometrial peristalsis? It is nothing but Braxton Hicks contractions. What is Braxton Hicks? It's nothing but labor pains. What is labor pains? Without which I won't come to existence. So there is a peristalsis, fundocervical, cervicofundal, and circumferential peristalsis as long as the female has estrogen. And those dynamic contractions and relaxations allow the sphincters of fallopian tube to work dynamically. There is no permanent hole. It's not a tap that you open the tap as soon as you want to open the tap. It is a living structure. If you're against the peristalsis, you will falsely declare tubal block. So you will see flow of the air. I play again. I play one more time. So this is not saline salpingography, it is air salpingography. Saline, I find it very difficult to see to this detail because white is better visible against black backdrop. So I prefer air compared to saline. Again, I'm showing the right fallopian tube. Now, this is the right fallopian tube. Because I'm pushing the uterus with the probe, the whole uterus went north and the tube came from 1 o'clock. It's going towards 7 o'clock. I'm sure you all agree. Clock position is something that I'll repeatedly talk because I'm not demonstrating in front of you. So uterus is somewhere here at around 2 o'clock place. I'm only showing the corneal entry of the air and slow spilling and then, sorry, slow filling, flowing and spilling. It loses the tubal contour when it comes out of the tube. Please watch. Please don't see, this is the bowel. You need to put the head down position, push the bowel away if you're not seeing. Tube is always there if it is there, unless they had a surgery before. So if the tube is there, if it is open, you must be able to see, because of the air allows the ultrasound to come back to you probe. So I showed left tube, I showed the right tube. This is air contrast salpingography. Mix 5 ml albumin, 5 ml of air, agitate with 2 10 ml syringes. You get a froth. Once froth goes away, you agitate again. So I changed most of the teaching hospitals in Dubai have replaced $200 media that they used to buy to do tube test with this. The reason being, ultrasound is more user-friendly, no radiation, no purchase, and also the fembrio-ovarian alignment can never be seen with HSG. Laparoscopy is there, which is a gold standard, but you're not jumping to do laparoscopy just to assess the tubal patency. So any questions? I would love to have interaction. I know the organizer, IT person, sometimes can raise the hands. Otherwise, I'll give a pause. I would rather have interaction rather than just keep on, dumping some information on you, what I do, how I do. I'm very particular about the couch, how to bend the head down.
We wanted to have a lot of discussions on all these things that we are talking about, but as we do not have running short of time, and still many people are interested in hysteroscopic talk also. We are not disturbing you, and we are just listening one-sided, so that
Okay,
the time is saved.
no worries. I understand. So I'm sure I already explained what is diagnostic test, what is screening test. I don't need to know, but I'll just show some examples where doctors should not be dogmatic. I did the scan, this lady, and I thought it's trilaminar. Thickness wise, it's okay. But I put the scope exactly within 2 minutes after this. I saw area of endometrial atrophy. I saw areas of endometrial sclerosis. I saw endometrial edema. I saw a polyp. I missed all the 4 pathologies on this ultrasound in the proliferative phase, which means please don't ask me to give second opinion on my ultrasound, because I'm like a toss of a coin. Half the time I'm right, half the time I'm wrong. I want to give an example. My sister, she studied until 4th class. She lives in a village in South India. She's very popular in her village area because she predicts after sex, a lady lies on her belly facing north, she's going to have a girl, and she lies on her back facing another direction, she will produce a boy. And she's always correct 50% of the time, my sister. So like that, there are many doctors, they're half the time they're correct. So my ultrasound finding is only half the time correct. In other words, I want to give a meta-analysis data here. If you do universal hysteroscopy before any fertility treatment, specifically IVF, okay, and you did not find any pathology, oh my God, I wasted the money. Why did I do hysteroscopy for this lady? I wasted. She could have had perforation, she could have infection, you can cry. But your clinical pregnancy rate will be at least 25% more by just doing universal hysteroscopy before the first IVF. You heard me? This is meta-analysis long time ago, 2014. 2016, another meta-analysis came, again from London. I know who they are, in St. Thomas Hospital, London. They're confirmed, if you do hysteroscopy and you found a pathology and you've treated, which means see and treat hysteroscopy in people with previous IVF failure or with first IVF, the increase in the live birth rate is 33% more. So you never lose by doing universal hysteroscopy. In other words, my ultrasound is wrong. My hysteroscopy gives more pregnancy rate. I have no single reason that I don't invest in a little piece of metal called hysteroscope. Ask your urologist, Ask them to lend you the pediatric cystoscope. They don't use it. And that is good enough to produce these images. These lenses from Germany, they don't lose their potency for 30 years. So please, there is always, if you have a sankalpam, you can achieve anything. When there is a will, there is a way. So I should not hear the reasons why you don't start hysteroscopy service. For this very reason, you are improving the success rates. You are not depending too much on your ultrasound. And most of the ultrasound machines are substandard to my experience where I travel. If you think you set up a unit, fertility center, and you want to grade that center is good, patients go there only for a baby. Doctors refer there only for a baby, and the other one is for referral fee. It doesn't matter. Practice of money in medicine is always there, but it doesn't matter. Entire America is a private practice predominantly. You have to pay for service, but they give 75% live birth rate, transferring less than 2 embryos. How? And you go to UK, we did the audit on 64 centers. Can you see London Fertility Center? The clinical pregnancy rate is 18.5. In the same year, at Center for CRGH, 52. You think it's a Great Britain? No, it is biased Britain. Why? You go to UK, you think you're going to get a high quality care. This is the range of pregnancy rate within UK, within same year, within the HFEA guidelines, within the RCOG guidelines, within whatever greatness you think they have or we have there. It doesn't matter. So it depends on the prognostication of the couple and the diligence of the healthcare provider. So you need to know who is going to get less than 5% pregnancy rate, who can get 50 to 80% pregnancy rate. That's the point I'm trying to make. That brings me to this. When I finish ultrasound, contrast ultrasound, hysteroscopy, DNA test of the sperm, universally to everybody, fat loss, of course, nutrient replacement, antioxidant replacement, I do everything ritually to everybody. I take 90 days to prepare a sperm, to remove free radicals or reactive oxygen species. One of your nutraceutical company, Universal NutriScience, are sponsoring this. I have been using these German nutrients, whether it is CoQ10 or we don't have extracts in Germany, plant extracts, which are researched in Ayurvedic medicine in India. We don't have that, but we know our free radical levels are very high. We know the sperm quality and oocyte quality, premature aging of the ovary, premature menopause is increasing. We know we are not healthy. We don't eat balanced diet. So knowing last kind of few hundred years of rice eating country and insulin insensitivity and other pollutants, we expect that we need to take supplements. So there is no question. I do that anyway, but I use German nutrients, because I have the huge research on patency on the German nutrients I use, which is called Fitline Germany. Why I'm saying this, if you looked after the sperm and egg 3 months before, and whatever rectification measures or reproductive surgery, ovarian PRP, ovarian stem cells, endometrial PRP, autoimmune correction, obesity correction, smoking correction, you've done everything possible in science and technology, and you gave them green criteria. My cumulative pregnancy rate in green criteria is 83.3%. I still have some embryos left in the bank. So cumulative pregnancy rate means you use all the eggs that you get from one team, which means you have a cricket team. You play all the 5 batsmen. Then only you declare the score. You have 5 bowlers, all right? You play all the 5 bowlers to get all the 10 wickets, whatever you want to call. So you need to use all the oocytes, all the embryos you make from one batch of eggs. The cumulative pregnancy rate in green profile should be 83%. In amber, after 2 to 3 batches of eggs, you may hit around 40 to 50% cumulative pregnancy rate. If it is red category, which means red sperm, red uterus, red ovary, you are stuck. At the most, even after 2 batches of eggs, you're stuck with around 7%. So prognostication is very important. It's almost like saying stage 4 malignancy, take home rate of your parents is very poor on there. And otherwise, if it is just a gestational trophoblastic disease, although you will call it as cancer or a Hodgkin, the cure rate can be 99%. We all know that. Choriocarcinoma cure rate is as high as 99%. So please understand, Please don't say, I am a senior clinician, I produce good pregnancy rate. I have embryoscope, I produce good pregnancy rate. I am FRCOG, I put good. This is all mythical illusions and delusions or delirium tremens. You don't need all that. You need facts in front of you. You need to have this jnanam of patient's profile. Diagnosis is 90% secret of success or failure. I use 2-page document. It's called consultation summary. Page 1, how do I diagnose? What are all the hardware, software that can go wrong in a man that stops man becoming father? What are all the hardware, software problems that can go wrong with a female? That's why they are in front of you in the consultation room. And what are the tests? What are the costs? What are the logistics? What are the complications? I say everything to every patient. My consultations are typically 90 minutes to 120 minutes. That is the first consultation. Not after 10 IVF failure, 20 miscarriages, which I deal with them in London. But the point is, everybody deserves the most exhaustive beginning, most fundamental foundation. Then as a couple, for me, IVF is a diagnostic test. Without actually you seeing the sperm DNA, without seeing the polar body of the oocyte, without seeing the blastocyst grade, without seeing the 46 chromosome present in the nucleus of a blastocyst, without seeing the cytoplasmic competency, which is called mitochondrial score, you are in darkness, you are in ajnanam, you are in avidya. So if doctor is in ajnanam or darkness, he cannot give 83% success rate. So share with the couple, at the point, there comes a point, you need to do an IVF to understand the fertilization happening or not. So IVF is a diagnostic test. PGT is a diagnostic test. Polar body is a diagnostic test. DNA integrity of the sperm is a diagnostic test. This will give you the credibility of the red category of the sperm, amber category of the sperm, green. If you don't know this, you will be sitting in a fluke doctor for the entire life of ART. One fine day, smarter clinic come and eat you for a breakfast. So this is my prognostication. You can apply in your clinic. If they are read based on this kind of validation, you tell them, I'm sorry, science and technology cannot help 90% of the time, even if you go to Cambridge, Oxford, Minnesota, Minneapolis, Columbia University Fertility Center. It doesn't matter where you go. Maybe the greatest embryologist, greatest embryoscope, greatest research fellow, senior most FRCOGs, it makes no difference whatsoever. Strength of the plant, strength of the soil, and the interaction between the embryo and endometrium, which is the guest and host relationship, must be diligently studied to the fullest detail before you start prescribing treatments to anybody. On page 2, I give success rate of 5 treatment options, including just laparoscopic ovarian drilling alone is the only treatment I give to some people. Hysteroscopic resection of the polyp or septum is the only treatment I give to some people. Genetic testing of embryo is the another way of to help couple. So it depends on the background medical information, the eligibility criteria for each treatment option, the cost and success of per cycle, per 3 IUIs, how much, for 6 IUIs, what is the success rate? For 9 IUIs, what is the success rate? Who is eligible for IUI? Who is eligible for Who is eligible for endometriotic surgery treatment? Taking second opinion, third opinion, so that you succeed. No patients I treat without general metabolism improvement of the obesity, the stress, the smoking, the malnutrition, vitamin D correction. That's why I see only 1 or 2 patients a day. These are the people who had 10 to 20 IVF failures or 10 to 20 miscarriages. That's where I practice currently. This is my detailed ultrasound report I showed in the other one. If you count it, there are 32 different details I assess. If I train you in one of the ultrasound training workshop, holding your hand and using the probe like this, I have one video I will share with you, anybody interested. I have vegetable cutting still images. That's how you will learn how to do longitudinal section and axial section of the ovary, how to do longitudinal section and axial section of the fallopian tube, normal fallopian tube, normal ovary, abnormal fallopian tube. So how do you scan ovary only? How do you scan tube? How do you scan structures below the right adnexa? How do you scan structures above? How do you get the longitudinal axis, the axial axis of the patient on the left adnexa, right adnexa, and the uterus? How diligently you assess myometrial pathology, endometrial pathologies with contrast scan 3D? How do you assess cervical pathology for predicting difficult IUI, difficult HSG, difficult embryo transfer? How do you assess uterine artery Doppler by scanning on either side? It's feeling like a radial pulse. Trust me, within 5 minutes, each one of you will learn how to do uterine Doppler if you allow me to come to scan a patient with you, hands-on. I've done this over and over again for thousands of doctors. So once you put all these details, when I give the report, I'm telling, sorry, your uterine artery Doppler has reverse diastolic flow. Therefore, I will give the vasodilators. Okay. I know you have PCO or not. Then I expect hyper response. So the stimulation dose will be different. I saw cervical canal is messy. I cannot see the continuous cervical canal. Therefore, you're going to have difficult IUI. Can you see? Every single thing ultrasound is telling me has a clinical relevance. If I say non-homogeneous endometrium, A means early proliferative, B means late proliferative, C means early luteal, D means late luteal. When I say antral follicle is 20/20, I don't do AMH, I don't do FSH, I don't do LH, I don't do anything. It's unnecessary waste of money and time for the patient. When I say this ovary is poorly visualized and access to vaginal egg collection is poor or doubtful, then I plan with my senior colleague with an abdominal needle guide that this patient is not suitable for vaginal egg collection. She is suitable for abdominal egg collection. I made the decision on the day of consulting, not in the OT. There is no fooling patients this day and age. The maximum possible information should be there. When I say she has adenomyosis, it is an autoimmune condition. The miscarriage rates are 4 times high. T-shaped uterine anomaly will be there. You can give GnRH analog by reading a journal, but it won't work unless you test endometrial immune profile, fix it. Immune system may be depressed. Immune system may be aggressive. It's called manic depressive psychosis. It's very common in adenomyosis. You cannot give immune suppression to everybody just because they have somebody told she had miscarriages, she had implantation failure. I'll give steroid, I'll give interlipid, I will give IVIGG. It is chaos in the doctor and chaos in the treatment and the chaotic outcome. Chaos. All based on the incomplete knowledge or short-sightedness. When I say uterine cavity is poorly visualized, I straight go for hysteroscopy under GA or idovaginoscopic hysteroscopy. We will see soon. When I say submucous fibroid, when I type it correctly, I will decide how complex the hysteroscopy surgery is going to be. I will use Shaver system instead of diathermy-based system because I know the complexity by doing saline scan. When I say this lady is pain during vaginal scan, I may have to do even HSG under GA because she already told me she has vaginismus. So I'll put the visual analog score. If it is pretty good, I do 80 to 90% of hysteroscopies, including mild to moderate pathologies, without general anesthesia, without conscious sedation, without spinal anesthesia. And when I say hydrosalpinx, you see them when the estrogen is high. You don't see them at baseline. So if at all you're worried about hydrosalpinges, you're going to scan them when the estrogen is high, not when the estrogen is low, less than 50 picograms. So when I see free fluid, I document before a collection. You know why? If you document some collection after a collection, you will not sleep that night properly. So I hope you all understand when you, without writing, committing, you're the doctor, this is your signature, this is your report, you're making a statement. If you give this paper anywhere in the world, they understood that you have spent a lot of quality diagnostic pathway in this patient management. There are times where I see the pelvis so messy, this patient goes for see and treat hysteroscopy before I transfer embryos. I never operate in any infertility patient without preserving fertility. It's too late and too little. They do tubal clipping, they clip even the ovarian artery supply. So AMH will come down. They do myomectomy, they damage the endometrium. They cause endometrial sclerosis. She cannot implant. She will have miscarriage, she will have IUGR, she will have abruption, she will have cesarean hysterectomy. So I'm very serious about spending quality time with a high quality ultrasound machine using normal 2D scan, 3D scan, contrast scan, and then couple it with a universal hysteroscopy. I hope this is the, I would say, for me, it's the best template how I approach infertile female. So I learned my miscarriage management or implantation failure management or ultrasound or hysteroscopy from AIMS, which is the top left. Then Bone Hall, Cambridge. Then this is St. Mary's Hospital, London, where I have to do my CCST. They don't trust my AIMS training is good enough. So I have to show all my obstetric skill, gynae skill, laparoscopy skill, whatever, in front of the examiners for me to get CCST. But because this is the world's largest miscarriage clinic, I spent time as a clinical fellow here. And this is Care Fertility, which is the world's highest implantation rate, which means for every single embryo you transfer, how many live births you have. It's not that you transfer 5 blastocysts, she got 1 baby. The implantation rate is 20%. But as far as you're concerned, you will claim you have 100% pregnancy rate, but you sacrificed 5 embryos to get 1 baby. So implantation rate is a better marker of a clinic quality. This is the man who invented ICSI. Is Simon Fischel. He's still alive and kicking. He hasn't invented ICSI. What he did, he was injecting sperm under the zona that is called SUSI, subzonal injection of sperm for male factor. You know what happened? Doctors were abroad were coming. Somebody from Europe came. His hands were not as strong as this guy, Simon Fischel. He accidentally injected the sperm inside the oolemma, inside the cytoplasm of the oocyte, then under the zona, between the oolemma and zona. So that became ICSI. So he had a better pregnancy rate. His name is ringing the bell all over the world. People forgot Simon Fischel. It is much difficult to put sperm between oolemma and the zona, which he invented. So the accidental hero is the ICSI Palermo. So this is Care Fertility Nottingham, designed in 22,000 square feet space, where I used to do 10 egg collections in the morning, around 12 embryo transfers in the evening. So approximately 22 cases a day. In 1 year, I collected 7,300 eggs in single year at this place in 2010. And I will tell you my zona fracture rate. Why I'm saying this, you need to maintain database on what you did. When you say there are 15 antral follicle, you should get 10 mature oocytes. When you get 10 mature oocytes, if your lab is good, you should get 7 day 1 embryos. When you get 7 day 1 embryos, you should get 5 day 3 embryos. When you get 5 day 3 embryos, you should get at least 3 blastocysts. And when you get 3 blastocysts, if you do PGD, at least 1 should be euploid. And that's for 1 baby from 1 team is the gold standard cumulative pregnancy rate from 1 batch of eggs. So whether it is recurrent implantation failures or recurrent miscarriages, the diagnostic pathway remain the same. Grossly speaking, I call A, B, C, D model to all my patients. A being, how do you assess the competency of embryo? B means, how do you assess the competency of the host? C means, how do you assess the interaction between the guest and host? It can be immigration check. It can be diplomatic relationship between the two. It can be catering between the two. Catering is thrombophilia screening, uterine artery blood flow. Immigration clearance is called natural killer cells testing. endometrial immune profile, serum immune profile, decidualization score. When I say diplomatic relationship between A and B, that is called HLA-DQ system. And if it is faulty, you use lymphocyte infusion therapy. If the C2, which is the immigration problem, if it is overactive, I use immune suppression. If it is underactive, I use immune stimulation. D means pelvic pathology, say hydrosalpinx. D means obesity. D means stress. D means anything else other than A and B and C, you need to fix. Severe fever, severe thyrotoxic crisis, whatever, severe illness, severe metabolic dysfunction. They are not conducive for implantation. Don't waste your embryos in that. And don't blame uterus for that. So when I say endometrium should be like this, I always do hysteroscopy in the luteal phase. Full stop. Because, you see all instructions in the toilet. Leave the toilet the way you found it. Or you tell your kids, leave the bedroom the way you found it to use for the night sleep. Same rule applies here. You only assess endometrium in the luteal phase so that you know when the embryo comes, it looks like a pink velvet cake, or we call it a pink seashore. If you put any of fingertip, it dips in. Embryo will dig in and to grow in the maternal sinusoids. All right. I almost always do 46 chromosome screening. I do mitochondrial score to minimize the treatment failure. I do uterine artery Doppler routinely. If the reverse diastolic, I improve it before I transfer embryos. And as I said, I do universal hysteroscopy anyway with vaginoscopic approach. And I do immunology test in Chicago only. It's not available in most countries. Only Chicago, Rosalind Franklin Reproductive Immunology Lab does it. We can use one-stop approach for male and female, I already mentioned before. Obviously, if you do genetic screening and if it is AGFC, post-meiotic arrest, 60% of the time, even azoospermia with AGFC, we can find sperm. If it is B and A, 99%, or I would say 90 to 99%, even with micro TC, you won't find sperm. So although you are doing FSH, and FSH will always be high if the testis is failing, same FSH is high if the ovary is failing. But if the FSH is normal and the testosterone is normal, 90 to 99%, you will find the sperm because manufacturing is on, transport is missing. Whereas if the FSH is high, testosterone is low, the manufacturing or testicular cause of azoospermia or oligospermia. Why do genetic testing routinely even for oligospermia? Because you can produce Klinefelter, another Klinefelter from there. You can produce YZ deletion. You can produce oligospermic father to produce azoospermic son through your IVF. They will hate you after 18 to 20 years when they come. Oh, you did IVF, my son became infertile. We are in a litigation-prone society. You need to be careful. You need to give correct information. As I said, out of every 10 gynecologists, one should be sexual dysfunction expert, both for male and female. Every single parameter in the semen analysis speaks of different male accessory glands. If there is no volume, you can unblock the seminal vesicle. That might be enough for him. Same applies to prostatitis. Okay, urethritis. So you must be diligent in interpreting every single thing, and you should know how to scan the groin easily. It's not difficult. As I said, you just need 10 scans with me or somebody who loves to try and scan in your own place. You need to chase urologists to train you. People are willing to share their knowledge because sattvikata is there at least 10% of our livelihood. We maintain sattvikata. The rest is rajasic and we get tired. We go to tamasic anyway. So sattvikata is what people prevail to teach each other. You can always learn how to scan the groin because testis is in your hand, the groin is in your hand, the linear probe is in your hand. 10 times you practice on 10 men, 10 staff. You will be very good in testicular scanning same day. 3 millimeters or more veins, you will see so easily. You know it is severe varicocele. We use sperm selection techniques. There are 6 techniques. If there is worst sperm and you don't have a choice, you can select the best boys out of the worst boys. Okay, best out of the worst. PICSI, IMSI, electrophoresis, biofluorescence, microfluidics. Without DNA integrity test, I never use the sperm for IUI, let alone for IVF or ICSI. If the DNA is not good, if the car engine is not good, car will not go far. If you're using an abnormal DNA sperm, even normal semen analysis, a third of the sperm will have abnormal DNA. Trust me, particularly people who are not ejaculating every 2 days, it's waste of time to use that sperm. You don't even know why IUI did not work, why IVF did not work, why ICSI did not work. You don't know because you never tested the DNA. This abnormal DNA integrity will go to the embryo, and uterus is the greatest soil. It will reject unfit life. 90% of the Down syndrome embryos are kicked out as miscarriage. 99% of the Turner syndrome embryos are kicked out by nature as miscarriage or blighted ovum. Nobody can stop it. You may be the greatest miscarriage expert. For the reasons of A, you cannot treat B and C. Okay? There is no treatment for A. A means embryoploidy. There is no treatment. You can throw away aneuploid embryos, but you cannot force create a euploid embryo. I wanted to share with you how the endometrial waves looks like, how the myometrial waves look like. So the commonest reason people are overdiagnosing polyps, polypoidal endometrium, abnormal endometrium, non-homogeneous endometrium, adenomyosis, because you are scanning when they are contracting. It's like you're taking picture of your child when he's jumping around with old camera. You're out of focus. You diagnose pathologies when there is no pathology. So watch carefully in this retroverted uterus how the endometrial peristalsis gives a false positive endometrial polyp or non-homogeneous endometrium, thin endometrium, thick endometrium, irregular thickening of endometrium, all sorts of doubts. You do unnecessary hysteroscopy for these people. If you are limited, you are a selective hysteroscopist. Or you diagnose polyp and you go to your colleague, she says there is no polyp. This woman doesn't know how to do scanning, or this man doesn't know what to do scanning. So we blame colleagues because we don't know the physiology of myometrium and endometrial waves. So I'm just zooming. This is the internal os level. This is the fundus. This is the anterior, the junction of endometrium. I'm sure you all see there is a movement of endometrium. The midline in the center is lost. I think there is a polyp here, but there is no polyp. Let me just paint something. Yeah. See now, this white line keep on moving. And there is a polyp-like structure I'm seeing here, but there is no polyp. It just disappears. And the endometrial edge just keeps coming like a sawtooth appearance. That is just endometrial waves. As I told you, this will become to menstrual contractions to menstruate. This will become Braxtonic contraction. This will become labor pains, without which third stage will be a nightmare. Almost all women will die if there are no such powerful contraction and retraction of a post-third stage uterus in labor room. Okay? So I just shown that in a still image, you can see endometrial waves. Some people measure thin endometrium during contraction, and they measure in the relaxation point thick. Never estimate endometrium in the axial plane, because you will see a single plane, you don't know where you are. In sagittal, you can see the entirety from internal os to the fundus. I hope you understood the importance. It's always there. We just don't pay attention.
So these endometrial contractions are there for how long at a
In
time?
5 minutes, Dr. Anita, Professor Anita, there are 3 contractions every 5 minutes.
So you have to wait for a few minutes and see whether the contraction passes off.
No, if there is no dancing endometrium, you don't need to wait. But you happen to be watching Shiva when he's dancing, not when he's in Yoga Nidra. You don't know when you watch him. He's Sarvantaryami, correct? So movement, Shakti is there. But she can be still also. When she's still, it's called Shiva. You can see these are all still. There is no endometrial waves here. Can you see? So it's early proliferative. All right?
Yes.
It's early luteal, mid luteal, late luteal. This is the correlation of histoscope. This is correlation with histology. This is ultrasound. You can keep one of these slides printed and PPT laminated, keep on your table. Depending on when you are scanning and scoping, you should see this beautiful red carpet, red velvet cake, or red gulab jamun. I use all this language. And when I scope them, patient is awake. They see, doctor, I don't have beautiful red carpet. I know why I'm not getting pregnant. Or they feel confident, I don't need surrogacy. I can become mother. Just maybe they need to get used to sourcing the gamete somewhere else, try longer. You can see the homogeneous myometrium, homogeneous endometrium from internal os to the fundus. Clear? And these white specks you see of the endometrial glands. Can you see the purple thing? The end-on view of the endometrial glands will look like white spots. You can see in this entire field, second slide, let me take pen. Please pay attention. In the proliferative phase, when you're scanning, you see so many blood vessels, okay? Dichotomous type of blood vessels. This mouths of glands, you will see like white spots. All right, can you see? And in the early luteal, mid luteal, late luteal, it's like lotus, bud, semi-open lotus, fully open lotus. It's late luteal phase, around day 22. That is the most invitational endometrial gland for implantation. By the way, when I implanted in my mother's uterus, I implanted only on 4 millimeter endometrium. There's the big statement I'm making today. If you're measuring the endometrium of the anterior uterine wall, which is 4 millimeter, combine it with 4 millimeter of the endometrium of the posterior uterine wall, together you call 8 millimeter. No embryo is capable of attaching both to the anterior wall and posterior wall. I cannot put one foot on there and there, right? I attach only to one surface because as blastocyst, when I attached my mother, I attached only to the 4 millimeter endometrium. So a woman needs only 4 millimeter thick endometrium for successful implantation, placentation, normal growth of fetus and embryo. Okay, so this 8 millimeter story, 7 millimeter, 6 millimeter, 5 millimeter, I do endometrial PRP, I do endometrial stem cell, I do Asherman syndrome surgery. Please think carefully what you are doing. Okay, if the basal endometrium, nobody can replace it's stem cells. We give stem cells, of course. If the spiral arteries are damaged, if the basal endometrium is damaged, whatever you do, nothing will work. If there is basal endometrium, you can nurture it with endometrial stem cells and mesenchymal stem cells or PRP or pentoxifillin to dissolve the scarring. Then there is a small oasis of endometrium where you can implant and grow. So please understand, implantation requires very tiny area of 4 millimeter endometrium because hatching blastocyst is only 0.3 millimeter. Okay. So I'm sliding into histoscopy lecture. I know it may be too much for an ultrasound, but it's always together. So early proliferative, I graded this endometrium based on my research in Cambridge with Addenbrooke Hospital, where early proliferative, late proliferative, early luteal, late luteal, based on the histology, ultrasound, followed by endometrial biopsy, followed histoscopy, endometrial biopsy, and then histopathology. So it's the histopathology graded endometrium. This is a gold standard in Bone Hall International as well as Bone Hall Cambridge. Since 2004, after 2 years of work, I published this. Already showed this. My ultrasound is unreliable. So I do histoscopy. That was proliferative phase. I thought I'm very good in luteal phase ultrasound. So I thought it's a beautiful 8 millimeter endometrium, completely white. I checked the progesterone. It is 20 nanograms. So I was happy. But I put the hysteroscope. This is what I expected to see. You know what I saw? I'm talking about me doing luteal phase ultrasound, TVS, with a good machine. It was Toshiba I was using in Cambridge. And then obviously, she had multiple implantation failure. That's why she came for hysteroscopy. At that time, they were doing only hysteroscopy for 3 IVF failure, 3 miscarriage. NHS doesn't have money. So they only use for selective. There is no such thing. You wait for 3 miscarriages, 3 please don't wait too fertile. So instead of finding a beautiful endometrium like this, in this case, I found these 3 pathologies: endometrial hypertrophy, endometrial atrophy due to this kind of non-dichotomous blood vessels, endometrial varicose veins. I'm sure those senior doctors listening to me, who you've been doing hysteroscopy for a number of years, you must have come across many pathologies endometrium in the abnormal bleeding clinics. But we are talking here is, we are talking ART endometrium. It should be like this. If it is not like this, forget about you succeeding. All right. So please guarantee uterine factor before you work IVF. No need to do IVF if the endometrium is irreparably damaged. So I shared the slides to these doctors that I coach. My first workshop in ultrasound in AIMS was 1989 on lower segment assessment with transabdominal scan and TVS, isthmosil assessment. Now the details of this is so high, yeah, that you can see the bladder with urine, you can see the bladder mucosa, you can see the detrusor muscle, one layer of bladder serosa, UV fold of peritoneum, where you call cave of Ritzius, or utrovesical fold, where you dissect and push the bladder away with bladder retractor, and you cut the anterior myometrium. But now here, there is a defect in the prior uterine scar. Now you can assess what is the remaining integrity of whatever tissue between the bladder serosa and the decidua or endometrium in the non-pregnant state. Accordingly, you make a risk profiling of the patient for antenatal care. Yeah, so how do you classify endometrium? I will give you 3 groups of endometrium. 4 types of endometrial changes in PCO, 4 types of endometrial changes in thin endometrium, 4 types of endometrial changes there in thick endometrium. Depending on the cause and the variety of these subcategories stratified, your treatment options will open up. I hope you understood as a summary. 4 ultrasound gradings, 4 gradings of ultrasound and hysteroscopy, 4 gradings of ultrasound and hysteroscopy, 4 grading of thick endometrium and ultrasound and hysteroscopy together. Treatment is different from 4 of them. Obviously, the first category doesn't need treatment in any of them. Ovulatory, fertile, normal estrogen, normal progesterone, 20% of PCO people, their endometrium is beautiful and normal. They're fertile. They came for something else and you say you have PCO. They said, what is PCO, doctor? Leave me alone. Don't do anything. I have completed my family. But she may come to you afterwards when 35, 40, 45, when the ovulation frequency comes down in PCO, they can come up with endometrial hyperplasia. Thin endometrium, thin and healthy, you don't need to do anything. She'll get pregnant. Thin and endometrial sclerosis, no one can help. Same applies here, thick endometrium. Thick and healthy, it's okay. Thick and unhealthy or hyperplasia with atypia, you are stuck. Or thick with endometrial cancer also sometimes you see. So you need to be careful. So you need to guide some of the people who don't know, who are watching their video of their living rooms and things. So somebody has to guide some of the videos I'm seeing. They need to know that they are being seen by everybody else. So in cervix, for a difficult ET, difficult IUI, difficult HSG cannulation, with hysteroscopy, you can diagnose what it is. You can fix them to avoid further. So anybody who is not using video properly, let them blind them. Otherwise, we'll be seeing their personal details. So this is the book where we are having the details of all the hysteroscopy findings in implantation failures. Okay, you can read this book chapter. Otherwise, anyone interested, just WhatsApp me. I'll send this book chapter free of charge, including all the images. So this is the second world's largest data on ultrasound, contrast scan, histology, histopathology, and luteal phase hysteroscopy findings and recurrent implantation failures. I did the tubal patency test with hyphozy or acozy in London Women's Clinic, 100 people. I cannot ask questions. Otherwise, if you are listening to me lecture hall, I will ask the question, how many people had bilateral tubal block? Please write down somewhere on a piece of paper and pencil or keep in your mind. I will not tell this answer. I will ask when I have the face-to-face interaction. How many people in inner London, in London Women's Clinic, had bilateral tubal block if you use ultrasound-based tubal patency test? You will tell me another time. I won't tell you. It was a surprise to me. That's why I'll keep it as a surprise. So I presented this research in Georgia, Atlanta in 2007 in States. If you're going to do ovarian PRP, you're going to measure ovarian volume. You're going to say small ovary, big ovary. You going to expect the antral follicle counts are good or not. You're going to expect this lady cannot grow follicles anymore, even with 450, 600 gonadotrophin. You need to understand the anatomy. Never put any needle in the hilus of the ovary. Never try to go to the medial end of the ovary. Of course, infundibulopelvic pelvic artery also comes from the right side. So avoid this kind of angles, which is almost, it depends on how you access the ovary. It's almost like 3 o'clock, 9 o'clock for uterus. What you know, same applies to the ovary also. You cannot see germinal vesicles. You cannot see preantral follicle. You can only see the antral follicles above 2 millimeter to 9 millimeter, which you call antral follicle. Trust me, for the index cycle, the cycle that you're going to treat, 5 to 9 millimeter antral follicles, almost 90% of them will respond. 2 to 4 millimeter, they may respond, but slowly, or they may not respond. And these are the ones which are suitable for dual stimulation protocol. So I'm just trying to give a lot of information in a very short time. For those people who are doing dual stimulation, you will understand. So the reason I call mid-cycle is in the mid-cycle, when I see a dominant follicle, I know the estrogen level will be around 300 to 500 picogram. And if there is no endometrial damage, the endometrial thickness will be 8 millimeters or more. And I can always count antral follicle throughout the menstrual cycle. I don't call them in the menses only. And if I have seen enough antral follicle, I don't do FSH, LH, EMH. And if I see endometrium this level, I see the follicle like this, I don't measure estradiol level. If I see white endometrium, I know the progesterone level is about 12 nanogram. That white, not because of endometrial wave. I always wait for the endometrial wave to appear and disappear before I trust myometrial echogenicity or abnormality or normality. It depends on the endometrial wave. Obviously, corpus luteum, sometimes you can see, sometimes you cannot see. Okay, color Doppler helps to some time, but it's not always. So for me, 80 to 90% of endocrine changes can be accurately assessed by ultrasound. So I don't make money spent by my patients. So I tell a little story, polycystic ovary and a normal ovary. Polycystic ovary is that lack of discipline between brain and ovary. They understand, right? Mother and father are telling something to teenage children. Teenage children rarely listen to the parents. In a family, I call in an ovary, mother is FSH, father is LH. So if mother influence should be 100, father LH should be 70. So LH value should be 30% lower than FSH. And that FSH domination happens because the GnRH pulsatility in pituitary is like a very slow motion sarigama padanisa. If it is like a break dance, sarigama padanisa, then that hyperpulsatility of GnRH will induce LH dominance from pituitary than FSH. So when father influence is too much on the girls in a typical conventional, traditional 100 years ago family, instead of learning Bharatanatyam and so on, they play cricket, they play snooker, they want to smoke, they want to have a shisha, they want to compete with boys in every sport possible. They refuse to marry because why should I get married? I know how to make money. I know how to live independently. All these things dominate. And I live in UK. I've treated 462 same-sex women or single women, 462 in 1 year in London Women's Clinic, right? Majority of the same-sex women are polycystic ovaries. They don't like men anymore. Out of this 462, 300 were married to a man before they finished family. They get bored of male and then they start to get married to female. They come to us in London Women Clinic, which is the world's largest lesbian clinic, where I worked for 1 year. Why I'm saying all this? The ovary almost behaving like testis because LH domination is there. What it does is, it doesn't allow this beautiful shortlisting of one girl, 60 girls, photographs, 20, we call them pelli chupulu in South India, something like, the girl meets boys, have a coffee or something like that, and then they choose one. Actually, mine was an arranged marriage. My mother saw around 60 to 100 girl photos. She shortlisted 20. I chose my wife only one. So 60, 12 weeks before ovulation, 2 weeks before ovulation, there are 20 follicle. On the day of ovulation, there is one. The rest of people will have khudkushi. They have programmed cell death called apoptosis. So if this beautiful 60 applications, 20 for the interview, one getting the job doesn't happen because of the FSH dominance over LH, if the LH tries to dominate, this shortlisting doesn't take place. All the 60 will come for the interview. All the 60 wants to do something, but not with a maturation. So too many follicle, nobody dominating, nobody ovulating, nobody producing enough luteinization. So that is the anarchy of polycystic ovary, simply because of hypothalamus doing a break dance instead of a proper Bharatanatyam or Kathakali or Kuchipudi. Doing break dance, Michael Jackson. That is hyperpulsatility of GnRH releasing factor, gonadotrophin releasing factor. That's because of insulin resistance or other reasons. So 60, 20, 1. This rhythm is missing. That's polycystic ovary. You can always see the size of the ovary on ultrasound. Too big, too small. You can decide what gonadotrophin based on the antral follicle count. You should know from my experience or other publications, antral follicle count should always be audited. This is the book chapter I already told you, showed the book chapter. You should know the physiological cysts and pathological cysts because of corpus luteal hematoma is extremely common. Dermoid cysts are extremely common. You can see here the details inside a, ovarian cyst. You think it's a follicular cyst because you gave Clomid. Next time she comes, see inside two nipple-like structures. So I was missing even a dermoid. Some types of dermoid early don't have the ugly face. It's not typical. So don't get into lull. In 3D, you can see a lot of details. This is again 3D. Just watch. Just I want to show one example of 3D. It looks like I'm in an aquarium inside a follicular cyst. And behind that, I can count antral follicles very well. Otherwise, I can't count them. So there is an advantage. And I'll close this video and play this video on the left. You can see the corpus luteal hematoma, partly organized blood clot. I don't know how to count antral follicle, but if I rotate, it's like rotating the structure. Where is my photo here? Let me, I'm here. Oops. Yeah, so we are showing this kind of thing. I don't know why you're sharing screening. I need to go back to my slides. So you can always see the target region of interest by rotating the ovary. Now you will see inferior. 3D will give you option to go below the ovary, in front of the ovary, medial side of the ovary, lateral side of the ovary, posterior. Because a 3D computation of sagittal plane, axial plane. That's what it means. Sorry, please confirm you're seeing my videos, one of you. Yes, thank you. So I'll just go to the next one. Yeah, chocolate cyst, endometrioma, fibroma, organized blood clot. It's just a matter of repeating the scan, you will get an idea. Just single scan, a different machine, it's not good enough. I already explained to you, proper assessment of antral follicle will allow proper fertility enhancing surgery. It's not called laparoscopic surgery. You need to be very clear in your definitions. It's called fertility enhancing surgery, not fertility deteriorating surgery. I had an old machine where by doing the axial view, if you see pupil-like endometrial chamber, that is unicornate uterus. You obviously two separate myometrial outline, that is the didelphys. And in this, in a 2D splitting endometrial chamber, you cannot separate myometrial dent is there or not. But that problem is no longer exist when you're doing 3D. So this is the anterior posterior view I mentioned before. You can see the myometrial flatness and the endometrial flatness. You can see T-shape anomaly. Everything takes 20 seconds. So anterior posterior view is called coronal plane. You can see the cesarean section scar here. And the unicornate means whether you see sagittal view or coronal view. In every view, I want to see myself. So is the relay continuing? Yeah. So this is the unicornate uterus, whether it is a sagittal view, right lateral sagittal, left sagittal, anterior posterior, posterior anterior, endometrial chamber is always I-shaped. You can see septate uterus, the myometrium is convex. And you can see the endometrium is concave, but myometrium is not concave. Myometrium has a adenomyosis on the top. So that gives funny shape endometrial chambers. Here also you can see asymmetric shapes. I need to come back again. Something I kept playing with it. It's just gone funny. Yeah. So I'm back to what I was today. So you can see this unicornate uterus. I'm just going to play the video. So this is the left sagittal view of the endometrial chamber. This is the anterior posterior view of the endometrium. And the probe is going all around, probe rotates, not you. That's again the left sagittal view. I'm coming to the left sagittal view, still I-shaped endometrial chamber. It's thin. She came post-menstrually. So I went off the scale, so the probe was away. So and then I came back. Now I'm seeing the anterior posterior view. So whichever way you look at it, the endometrial cavity looks like an I shape that confirms unicornate uterus. So with 3D, you don't need MRI or laparoscopy or CT scan to diagnose. And if at all you are going to treat a deep septate uterus, you can reduce complete septum to incomplete septum and subseptate. Obviously, you all know when to stop. Surgery is about maintaining the vascularity properly so that she can become pregnant after your so-called surgery. If I'm going to do saline scan, I need to occlude the external os. If I'm going to build the pressure in the uterine cavity to open the tube, I need to occlude the internal os. You can use any instrument you have. Just a pediatric Foley's catheter will do, or any cannula that's got a cone shape is enough to do. Just fill the saline without any water, prime the catheter. You can do saline scan. But if you want to build the pressure, intrauterine pressure, 60 to 80 millimeters of mercury, you can open the fallopian tube. So you can see the salpingography. For hysterography, I need saline. For salpingography, I need the air. As I said, air trapping is easy if you use the albumin. If you see punching or pinching of endometrium into myometrium, that is a tissue, and different shades, then you can diagnose adenomyosis. Now, what you see on this side is Nabothian cysts. It's like a floating paradise through the bladder. Some people say they are follicles, so be careful. There are a lot of things which are not follicles. You will be operating. How do you do saline scan or gel contrast scan? Sometimes the cervical mucus in PCO or isthmocele is enough for the fluid to go into the uterine cavity because of the cervicofundal contractions in the mid-cycle. Okay, so I'm teaching here just a practical technique. It's not a hands-on ultrasound workup. You'll always see the bladder. You will always see the superior surface of bladder. You will always see the posterior surface of bladder. And this is the TV probe. And you are pressing the upper 1/3 of the vagina in the anterior fornix. This white line will give an arbitrary line of internal os level. Anything above is the endometrial cavity. Anything below is the cervical cavity. This is the most objective way, according to me, to measure the cervical canal length in the obstetric cases, non-obstetric cases, to indicate cerclage, whether it is emergency cerclage, elective cerclage, it doesn't matter. I hope you understood. This is a natural saline scan because of the mucus in the stimulated ovary or in the mid-cycle. That mucus traveling up and down because uterus has a habit of sucking sperm. It's called cervicofundal contractions or junctional zone contractions. When the embryo is trying to come post day 5 embryo need to arrive into the uterine cavity, there is fundocervical contractions. And also during menstruation, to shed the gangrenous endometrium, you need fundocervical, that is called menstrual contractions. Circumferential contractions happen during pregnancy for implantation to improve the maternal sinusoid lacunae. So because of this technique, always succeed in teaching everybody how to diagnose internal os just on one side of this. So I'm scanning, it's in the vagina. Okay, that is the probe. By just tilting the probe to the left of the cervix, you will see left uterine artery, or not even tilting, angling. Probe cannot go because the vagina is wedging the probe. You can only angle it a little bit. By that little angle, the ultrasound rays are falling outside the cervical canal into the left uterine artery. And by tilting the head of the probe towards the left shoulder of the patient, you can see that side. Okay, it's very easy to consistently identify internal os level, uterine artery level, without your seniors challenging your finding. He says you is right, you're wrong. No, when there is an objective evidence, you are right. Again, what is the benefit of saline scan? You can see endometrium looks same, but if you put a bit of saline, you see the difference. Here you see cauliflower endometrium. Here you see a beautiful, healthy, normal endometrium, which is 4 millimeter there, 4 millimeter here. If the embryo implants into the flat surface, it gets all the nutrients. Here, you can see the endometrium is polypoidal. Embryo will grow when in a flat endometrium, it will not grow in a polypoidal. So I'll quickly, uterine cavity fluid is very common. With uterine contractions, it can go away. If not, in the estrogen phase, you can remove by giving a nice lavage with the embryo culture fluid. Endometriosis, rectovaginal endometriosis, it's a different lecture. I will not go to many details. This is just a saline scan to say you can identify polyps very nicely. You can decide how easy it's going to be. You can also see it is just a one polyp. You may need, you use surgery. If it is polypoidal endometrium, you do medical curettage. You can see single polyp without even contrast on 3D. The machines are so accurate. You can see endocervical polyp, just a liquid in the vagina, in the uterine cavity. This is the endometrium. Here, you can see adenomyosis in the making. This is just a simple contrast 3D, anterior-posterior view of the endometrial chamber. This is polypoidal endometrium. If you do the hysteroscope soon after, you will see elevated endometrium. You do biopsy, selective biopsy, like a fractional curettage or a hysteroscopy guided biopsy. 90% of the time, they will only say it's just a proliferative endometrium or secretory, depending on when you did it. So I was disappointed. Then I realized when I was attending all the international courses, the reproductive pathologist diagnoses subtle pathologies rather than a general pathologist. It's like a lab technician doing semen analysis and an embryologist doing a semen analysis. The lab technician does the pus test, urine test, blood test, stool test, I don't know, all the tests. He cannot be a specialist. So if you give reproductive pathologist, they can pick up subtle pathologies. Say in UK, we have a specialist, a placental pathologist. Trust me, every placenta, if they suspect there is a placental reason for fresh stillbirth, IGR, oligohydramnios, abruption, whatever, unexplained stillbirths, unexplained miscarriages, we send placentas separately to this single guy in London in Gosh. Gosh means Great Ormond Street Hospital for Sick Children, London, right? He is a super specialist in placenta. So that's how the science is evolving. We cannot lay back and say the science will rain upon us. We need to do research. So this is normal endometrium. This is polypoidal endometrium. I do medical curettage for them. PCO, I already explained. There are 4 types of endometrium. Is anybody talking to me? No. So I'll move on. There are 4 types of endometrium. One with beautiful luteal endometrium, other one with luteal phase deficiency, other one with hyperplastic endometrium, other one with no endometrium. You know all these presentations, phenotype of PCO. Accordingly, you groom the endometrium for 3 to 6 months before you transfer embryo or before you transfer sperm for IUI. Because neglected garden for 10 to 15 years, suddenly in 15 days, you cannot grow beautiful meadows. Let's use common sense. As I said, reverse diastolic flow, were very common in some PCO. I fix it. Edematous endometrium is also common. I put a hysteroscope. In the anterior wall, there is edema. In the posterior wall, there is proliferative endometrium. So asynchronous endometrium is very common in PCO. You need to correct it. In the mid-cycle, with the estrogen level of 1000 picogram, if you see the endometrium like this is Asherman syndrome or endometrial sclerosis or a combination of both. This is a case for surrogacy. It takes less than 10 seconds to diagnose who needs surrogacy. Let's not waste patients' time. If you see polyp, there may be polypoidal endometrium. There may be more than one polyp. If you see one fibroid, almost 2/3 of them will have more fibroids. So please don't be dogmatic. When you see something, go for a hysteroscopy. Don't rely too much on ultrasound. This lady had 6 polyps removed. After 1 year, she has another 6 polyps. So by dissolving this with GnRH analog, she had a spontaneous pregnancy after 3 failed embryo transfer treatment. So I don't transfer embryos or IUI when the endometrium is not optimal. I fix it before I encourage them to fall attempts. In 3D contrast scan, the details of the polyp and irregular thickening of endometrium, which means it's only a matter of time. You do polypectomy, 6 months later, she has another polyp. You do DNC, she has 3 more polyps after your DNC. I've seen countless people till date doing still DNC in infertility practice. It is a crime. In contrast 3D scan, say in 2D, I saw 1 polyp. And then I'll write a story. Oh, 1 polyp, 5 millimeter, it is not the cause of implantation failure. Royal College guidelines says, you don't need to remove a polyp less than 1 centimeter. You can hear all sorts of stories. But if you do 3D contrast, can you see? There is 1 polyp here, there is 1 polyp, there is one in the making. If you decide your hysteroscopy based on this, you are missing this. So please, out of 100 ultrasonographers, one should have the most advanced 3D ultrasound machine. Can you see? It almost looks like cancer. On 2D, I saw only 2 polyps, 2D saline. In 3D, can you see what I'm seeing? I'm inside a cave. There is no man-made tunnel. It is a cave. I don't know, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 polyps. I call it as cauliflower endometrium, not any other word, because short of words. You can see Just by cell and scan introduction alone in PCO, you're going to avoid IUI failures in PCO, IVF failures in PCO, because PCO means their endometrial grooming, growing and moving, growing the lawn, moving the lawn, is not like it. It's like a West Indian hairstyle. You know, West Indian, you've seen Chris Gales, many West Indians, or some rishis, some, you know, some Shiva Bhaktas in Kashi, you know, Aghoris. Their head is so knotted, you know, you cannot just comb them. Your comb will break, right? So that is polypoidal endometrium because there is no regular growing and shaving. All right. You take time to fix it. I use GnRH analog therapy sometimes 9 months to get this right, inducing hystertrophy. You can see here. It looks like a tragic endometrium. You're only interested in how do you use myomas with 3D? Myomas not affecting endometrium, I will not remove. Adenomyosis not affecting endometrium, I will not remove. Whatever be the size. Obviously, if it is too large, you think it's an obstetric complication, you remove them. Otherwise, you peel off this myometrium with myoma, you will destroy the entire endometrium adjacent to it forever. Okay. And superimposing of anterior posterior fibroid, people write indenting of endometrium. Can you see in the 2D, it says indenting endometrium. Can you see 3D axial view by rotating? You can rotate uterus 360 degrees like a doll when you do obstetric drilling, how to train forceps delivery, instrumental delivery. You hold the doll, you turn the head the way you want. Even if you do manual rotation of the head for deep transverse arrest, deflexed head, you do all sorts of rotations. The 3D will rotate everything. It will give you the superior inferior view, which clearly shows this myoma is not denting the endometrium. But this is our traditional teaching. We have been programmed with less technology for decades. And we are carrying out the wisdom. No, that is not wisdom. That was wisdom applicable to 30 years ago, is not no longer wisdom. It is redundant. It is a dinosaur wisdom. There are no dinosaurs anymore. So we need to have much more accurate. Without hysteroscopy, I don't decide embryo transfer because of this reason. This will be the last slide because there are many and I need to do hysteroscopy. I want to give another break and in half an hour, I'll finish hysteroscopy so that you can carry on with your social duties. So this is the left sagittal view of the endometrial cavity with saline 3D contrast scan in a glass view. So that's the left sagittal view. Accidentally, I went posterior anterior view. I was not getting information. Okay, so then I rotated to left lateral view. Sorry, that is left lateral. Now I'm moving to anterior posterior. So watch carefully. Okay, I freeze there. So this is just a 20 seconds video. Machine does it for you. Once you buy the machine, you will do automatically. You just need 1 day training. So you can see the myometrial outline. You can see the endometrial outline. Fundus, left lateral, right lateral. You can see the endometrial cavity, no synechia, no submucous fibroid, no uneven endometrial thickening, everything in 20 seconds. Is this okay if I park here and then move to the hysteroscopy for 30 minutes? Please, organizers, reconfirm. You can have a little break, 5 minutes.
It will be 10:45 at night here in India. So, so actually, we
Yeah,
have to do
I get the message. You want to do hysteroscopy. I have shown the glimpse of hysteroscopy anyway.
Yes.
It's up to you, doctors. You know, you need to organize another webinar. That's okay. But you see, I feel justified in what I said today. It's not about throwing 200 slides at you.
Yes, yes.
Yeah.
Each and every sentence of yours were so much effective in making our knowledge enriched. I cannot explain it. But I think each part of your talk needs 1.5 to 2 hours so that we all are able to follow each and everything that you wanted to convey to us. But most of the time we could follow what you had been describing about. But regarding the technology, we are still far behind. And I think it will take another 1 decade at least, even if you move very fast, that we can avail all sorts of things that you expect, like DNA testing, and these high standard ultrasound machines are available everywhere. So it was just like a dream to us at the moment. I don't know when we are going to have all these things in our practice and give advantage to patients.
I can help you with that, Professor. I'll arrange this machine to be delivered to your training center. I explained to Dr. Shashibala how to go about
So
answering me.
nice of you, if you can do this, at least one machine in Bihar, and few people get trained here. And many of them at least can buy those machines, but unless and until you do have the glimpse of the things like that you have shown to us, I think it is very tempting. But looking at the price, I think most of the people will withdraw it. But once you actually see the machine and see what you can do with that machine, I think more and more people will consider buying it on their own also. So actually we need one machine so that we can see and appreciate the things, how in detail you can know the things from before. Whatever you are doing, you are planning to go for hysteroscopy or any laparoscopic fertility enhancing surgery or IVF. I think all this knowledge from before is very, very important if you really need to have a good success rate.
So if you're going to wind up, I would like a bit of general feedback from other doctors, anybody who is connected to this lecture. I know Professor said she has her own wisdom, her background. She might think, she may not see what young generation doctors who are entrepreneurs, who may have connections with investors. I want to listen from another generation of doctors who are listening to me on, as I said before, it's not difficult to organize training program, not at all. I'm done from Pakistan. Typically, the salary of Pakistan gynecologist, please listen to this carefully, is $300 per month. Trust me. So there also I'm going training, right? So mind is the limiting factor. Money will follow, and gynecologist, banks will trust you. We'll go about it. You know, I can help behind the screens how to organize funding, but I just want a feedback from, is this the way of learning going forward for gynecologist using ultrasound, and to some extent I touch base hysteroscopy. So if I can listen to one or two more people, if that's okay.
I'm Dr. Dhilan. I am practicing gynecologist in Pune, where I am a professor in a medical college. And we run courses where we teach sonography and its correlation with hysteroscopy. We have integrated this teaching of sonography into hysteroscopy. So we do hysteroscopy. We first analyze the patient by the history taking examinations. We do 2D scan, a 3D scan. We find out the pathology and then post for hysteroscopy. That is the way we have gone ahead in our training programs in Pune. We do a lot of hysteroscopies and office-based hysteroscopies. In fact, I have the largest publication in India on office hysteroscopy, which has been there. But I agree to what you have said, that we should embrace technology for patient betterment. And I do understand there can be a hurdle in the money of money, but no, as I have personally seen in my practice, when you start pursuing and following technology and using it to the fullest for the patient, and I agree in total with what all you said. In fact, I preach somewhat 50% of what you have said, not maybe in Sanskrit, but in my own language, the way I communicate with my students. But that is the same way that we have to teach, there has to be a guru, we have to see, we have to create clones that I cannot suffice, you cannot suffice. There have to be clones created of yours to teach, go ahead and teach ahead to the next generation. And I fully agree that sonography is a boon in ART, is a boon in AUB disorders, and it definitely gives you what is to be done in hysteroscopy or laparoscopy. But it has to be used very methodically, it has to be protocol based, as you have shown all the templates, and I admire you for that. Extremely, I'll tell you, you are, I've seen one of the most learned teachers today, and I've heard and I have myself learned now how I am supposed to teach and go ahead in my life. So I, from the bottom of my heart, say thank you, and I'm so blessed that Shashiwala called me here to Patna from Pune, and I was lucky that I heard your lecture uh, from London. So thank you so much, Professor.
Can I ask
Can I
other
ask,
delegates about budding
Yes,
gynecologists?
I'm happy to, yes, sir. First of all, I would like to hand over mic to one of my senior. She's Dr. Rupasri Purushottam from Ranchi Aveta IVF Center, sir. So she would like to convey to that.
So first of all, your talk was mesmerizing and enlightening us, but you haven't left any stone unturned, and you give in and out of everything, like from the beginning, like what is the importance of endometrium, ovary, and seeing each and everything in that Nexa. And what, as a practitioner of IVF, what I found the most difficult one is to treat the choice should be good. As you have said that this is the most important thing, because we know that yes, if need we can change X, we can change sperm, but we can't change the uterus. So it's the most important thing, and I think this is the most important parameter for the successful outcome of the ART. And the way you dealt with everything. But I think, sir, as you have described it in a very descriptive manner, so more webinars should be there, because as a student we want to learn each and everything, and get everything in one lecture, it's very difficult. And as I discussed with all my colleagues who are present here, and everybody is saying that if we could get the opportunity to keep the frequent webinars from your side, so that we can learn in a short manner, like thin endometrium, like fluid in endometrium. So it would be helpful to us, where we can ask questions to you and put all queries, because there were lots of things, there were lots of questions which were running in the mind, but as we don't have that much time, so if you can plan, or if you can do this much help to us, it would be great for all of the practitioners who are practicing ART or anything like infertility, not ART, it's infertility. Like many of the gynecologists not doing IVF, but they are dealing with infertility and they are doing good. So, sir, if you can do something, I will request Shashi Bala to give link, and so that we can connect you in some way, sir. So thank you so much, sir, for your wonderful talk, and giving us the opportunity to listen from such a great academician, sir. So really mesmerized by your talk. Thank you so much, sir. So
I would
now
like at least one solution-centric doctor, which means I just need somebody who will engineer with Sankalpam how to create funds for a training platform in wherever it is self-propagatory and self-sufficient system. Because I don't talk for compliments. I don't talk without passing on cloning me. I'm lost. I'm lost for the last 40 years. Talking doesn't help us. We need to create a system of training. I want to clone myself. I want some constructive commentary, or in the next webinar, please do something about having enough funding locally to have a training platform. It's just a matter of time. High-class training can be done consistently and repeatedly. I have a lot of people who want to do the job that I do, but it needs to be dissipating other people. The few greatest professor always existed all over the globe for centuries. But we need a system where confidently MD, MS gynecologist will go and learn what they want to learn.
Actually, we have started doing that type of programs, and this, I think, the program hosted by Dr. Shashibala is one step towards that. And I hope in the future, with your suggestion, we are going to have a group meeting amongst ourselves, and definitely work on that line, and we'll take help from you.
Sir,
Okay.
so thank you so much. And I personally feel that I have already started, working about the program you are talking about. So, and I expect, help from some pharma people,
the company sponsoring for this type of events like Stoge and many more. They may help us, sir, and in the near future we will organize such event and we'll look for your cooperation also. So thank you so much, sir. And I think we will have another webinar on hysteroscopy exclusively very soon, sir.
Okay, are we closing now?
Thank you. Yes, sir. Thank you
Are
so
we
much,
closing?
sir.
Okay, namaste everyone.
Namaste, sir. Pranam, sir.
Pranam.